Everybody, please.
So we are live.
Please mute.
Good evening, everybody. Requesting all participants to kindly mute your audio and video. Requesting everybody to kindly mute your video and audio. Welcome you all to the last episode of season 2. We have a panel discussion today to discuss all the different what we have gone through with all the lectures so far. Over to you, Amit.
Yeah, thank you, Preetham. Good evening, everyone. I'm here to introduce our co-host. Am I audible?
Amit, now it's audible. Yeah.
Now it is better, Amit. Yeah.
So I'm going to introduce the YouTube co-host for the day. Today, Dr. Senthil Kumar. He's from Dindigul. Senthil, he wants to just say hi.
Hello, good evening, everybody. Hello. Hi.
Yeah, Dr. Avi will be helping him in YouTube. Dr. Avi.
Hi everyone.
Yeah. Then we have 3 co-hosts for the Zoom as well. Dr. Mukul Padhyay. Mukul sir, you want to say hi?
Hi. I'm on YouTube. Hi.
Dr. Nitin Ahuja.
Yes, sir. I am also on YouTube actually.
Yeah, okay. Senthil, Nitin and me are on YouTube.
Okay.
Yeah.
So Dr. Venkat Nag. I think he has not yet joined. Yeah. Over to you, Kanan. Kanan, are you there?
Kanan.
I cannot start because my video has been disabled.
Okay, wait. You can. Yeah, you are on. Yeah.
Thanks, Amit. Thanks, Preetham. Hello, everyone. Welcome to the last session of the webinar 2 series. Today is a swashbuckling day. We have all the gladiators in the arena. It's like the famous 5 coming on board. So to start off in the same, our panelists will have the enigmatic Samir Kaura. Sam, do you want to say hi?
Hi guys.
And followed by Dr. Prasanth Pillai. He had a fantastic series with his hybrid implants. Dr. Prasanth, do you want to say hi? Dr. Prasanth? Dr. Prasanth, I think as we are waiting, we'll move on. Then we
Prasanth sir, you need to unmute and say hi.
Okay.
I have unmuted him.
Do you want to say hi? Yeah.
Hi, all of you. Wonderful being here.
Our next panelist is Dr. Sankalp Mittal, who was talking to us 2 days ago. Sankalp, do you want to say hi?
Hello, everyone.
Sankalp, is your video on? Yeah,
Is it
now
okay?
we can see.
Yeah. Hello, everyone. Good evening, everyone.
Then we have Dr. Gunaseelan. Dr. Gunaseelan Rajan talked to us about zygoma implants a couple of days ago. So Guna sir,
good evening.
Just give a wave. Yeah. Nice to have you.
Thank you.
And our last panelist for the day is our incoming or who will be taking over next year, our Honorary General Secretary elect and an eminent implantologist, Dr. Girish Rao. Girish, do you want to say hi?
Hi, everybody. Good evening.
Girish Rao. Your video isn't there. Yeah. Now we can see you. Bright and smiling.
Good evening.
Over to you, Pramod.
Thanks, Kanan. Our moderator for the day is going to be Anjan Shah. Anjan has organized the entire scientific structure of this implant series. I think he knows what he is doing to himself today. It's going to be a very tough job today. You have 5 excellent speakers, 5 different treatment systems, platforms, techniques, and and you're going to give them a chance to speak. And I hope you know what you have got yourself into. But I'm sure I'm going to enjoy it. Okay, so looking forward to that. I would also like to acknowledge the presence of our president, Dr. Veerababu here.
Hi.
Hi, sir. He is the one who pushed us to start this web series, and we are thankful to you for pushing us to do it, and it has come a long way. Thank you so much. And I would also like to, at this point, introduce Dr. Bhagwandas Rai. He is the chairman of our the social media. Social media committee of social media committee of AOMSI, and he has done a wonderful job with the Twitter, and he wants to take it forward. Now our YouTube channel has 2,000 subscribers, and the Twitter has also been going very well. It has grown from 50 to 1,600 in over a period of a year, and he wants to talk to the listeners and to the AOMSI members through this at this point in time. So, do you want to come in and take over?
Everyone, good evening. Praveen, can I have the screen share, please? As you are all aware that AOMSI is involved in all other activities and has its presence in the social media on Facebook, Instagram, and Twitter. Most of us are very familiar with Facebook and Instagram. Though we have heard about Twitter, we are not very active on Twitter. But Twitter is a wonderful platform where you can convey a message in a very short and sweet way. So AOMSI has a Twitter account which was opened in 2017. And what is displayed in the screen, you can see that is the account which is there. Can we go to the next slide? So as of now, we have around 1,631 followers. So the number of followers determines like how we have YouTube followers or YouTube viewers, how we have, our presence is counted. So this Twitter account, you can motivate who are not on Twitter right now. You can motivate others who are not on Twitter. It need not have to be maxillofacial surgeons alone. It can be the medical colleagues. It can be our friends, anybody from the society who would like to have an interest in knowing what is maxillofacial surgery, the various procedures and other things. So can we go to the next slide, please? So as one of our resident has told, please follow the Twitter. It's not only for the medical professionals, it is for all section of the society who would like to know about the various treatment options, right from starting from implants to surgical removal of third molars or any other surgical surgical procedure, including complex surgical procedures like craniofacial deformity corrections, everything, all informations are there through the Twitter we can access. So you have enjoyed the web series 1. You had a great response which you have given, which motivated the team to come to the season 2, and season 2 even was bigger success. I think the team will be motivated to go for season 3. Before we go for season 3, a small survey has been created, which you can see. You would have access through Zoom, you would have access through YouTube live, or some of you would have gone to YouTube later and viewed. We would like to have a view of what medium you have chosen in this series, so which will help us to improve on and deliver it better in the season 3. So in this regard, coming to the last slide, so the AOMSI has already sent an SMS to, hope you all received, all the life members and student life members would have received an SMS because your database is there with the AOMSI, and other maxillofacial surgeons and other specialists who have accessed this web series would not have received an SMS, but you can as well connect to us through the Twitter, and you can express your opinion or you can give your opinion on the Twitter, whether you have access through Zoom or whether on YouTube or later on YouTube. Thank you.
Thank you, sir. Thank you, sir. I would request everybody to log into their Twitter account and then take the survey. If you don't have a Twitter account, please do start it with your account, not in the survey. At this point, again, I would like to request all participants to kindly, thank you, Vijay. I see that you have already done that. Everybody, please mute your and stop your video, your audio, and stop your video. Any questions at any point in time can be forwarded on YouTube through the YouTube chat to the YouTube co-hosts, and on Zoom to the on the Zoom chat to the Zoom co-hosts. They will be taken up for discussion by the moderators. Praveen, you can start the music, and after that, Anjan will take over.
Anjan, please start.
Good evening, everyone. And just give me a moment to get my screen up. But while that's coming up, I think thanks, Pramod, for that introduction and the comment about the daunting task that I have ahead. To that, I would like to say, probably reply to that with a little song from the Beatles. I'll get by with a little help from my friends.
Praveen, can you help him to share the screen, please?
Yeah. Sir, open the PPT, sir.
Okay, yeah, let me just. Okay. Okay. I'm also just going to keep my DTX open as well, just in case. Right. Okay, so good evening, everyone. And this is really a culmination of a 6-day program. We've looked at various options of treatment, and we've heard from some very good speakers who've brought out all the pros and cons of various techniques. They've shown you a lot of cases. They've also shown a lot of their complications and how to manage them, which is very, very important. Something which you probably wouldn't get from company videos. So I think that's been fantastic. But there may be some topics which may not have been discussed, and that's what we thought we'll try to bring up in the panel discussion. We have 5 very experienced implantologists, and we also have a prosthodontist, Dr. Venkatnag, live over here on Zoom. So we can ask questions to all of them, address both the surgical and the prosthetic issues that we have with the resorbed bridges. So the outline of what we were going to discuss is we were going to look at some of the patient factors which influence implant success. How do we assess them, and how do we decide based on the patient's factors whether that would lead us to a particular type of treatment option or the other. Then we look at the surgical factors, how different people do surgery differently, starting from how you would take a tooth out and manage the socket all the way to the actual implant placement and the loading of the implant, how different people would do it differently. The third part will be the treatment options, and what we were going to do is bring up a series of patients and who are all patients with resorbed ridges, and see how they can be managed differently, and how the same situation can be managed in different ways depending on your skills, depending on various patient factors. And finally, how do we manage complications and failures? And again, we have a panel of very experienced surgeons and prosthodontists here, and we can address how to manage these complications and how to avoid failures. So this is really just a summary list of the things that we've discussed over the last few days, and you can see there are a number of techniques that we can use to handle the same situation. And sometimes when the young budding implantologist, sometimes it means that we have too much of choice. Which particular treatment option will work in your hands or will suit your patient? And that's what this panel discussion is hopefully going to be about how to decide what treatment would work, or what would be more successful. So we'll start by talking about the systemic factors which affect implant success, things like smoking. So whether smoking would affect your treatment plan. If a patient was a heavy smoker, would you choose a particular treatment option versus another one? We'll see an example of that. We look at periodontally compromised patients with diabetes as well, whether that would affect, whether you would choose a particular treatment plan or the type of prosthesis as well. And then we'll discuss a little bit about age. Does it affect the treatment plan? So we will take those topics in a little bit more detail, but one of the few questions which had come up over the last few days, which probably we haven't quite answered, and if I can put that to the panel, is patients on immunosuppressants, patients who are on, say, methotrexate or long-term steroid therapy. What would be your management? Would you do anything differently for these patients when managing them for implants? Or would you just carry on with the same treatment that you would for a healthy patient? Maybe we can start with the first panelist, Dr. Samir. Samir, is your mic on?
Yeah, can you hear me?
Yeah. So yeah, what's your take on this? Things like methotrexate, long-term steroid therapy, patients with arthritis, for example.
I think
do you do anything?
There's a lot of literature which says that long-term use of this methotrexate can interfere with some kind of bone healing. So if a patient is on for methotrexate for long-term, I try and avoid for some time, and I'm like a little more cautious in placing my implants in patients who are on long-term methotrexate. Yeah. For steroids, not really. I haven't faced any problems yet. But yes, with methotrexate, I'm slightly more worried.
Okay. I think some of these questions that come up during Dr. Gunaseelan's lecture actually as well. So Gunnar, would you have any thing to add to that?
Yeah, any immunosuppressant, for example, methotrexate or cyclosporin, I think we need to be cautious. Although there's no clear-cut evidence that there's no literature which says yes or no. There's conflicting evidence as of now. So we have to take a call on individual patient. And long-term steroid therapy, I think you should always look at, I strongly feel you should look at everything together, not just in isolation. If you're on long-term steroid therapy, whether they are osteoporotic, whether they are smokers, whether they have got bruxism, whether you're doing the maxilla or mandible, I would look at those other factors in addition.
Okay. And what about osteoporosis? If they had osteoporosis in other long bones, would that affect your treatment, or is the jaw independent of long bone osteoporosis?
Today there is no correlation between long bone osteoporosis and the jaw osteoporosis actually. So we can't really look at DEXA scan as a reliable indicator. I would rely more on your CBCT or CT scan and look at the local bone quality, the Hounsfield units, what comes on the CT scan, or on your CBCT, go on the grayscale and get the help of a radiologist to decide what sort of bone density you have in your jaw bones, and then go by that. And of course, if you have option of osteoporosis, to check for if they're on any bisphosphonates or one of the newer medications like monoclonal antibodies or teriparatide, which are all newer ones which have less problems compared to the IV bisphosphonates. So that's how I would look at it.
I have a point there, Anjan. In case of osteoporosis, we have absolutely no contraindication as such for corticobasal implants because we rely on the basal cortical bone, where there is very minimal bone remodeling happening. And we don't rely on the crestal bone usually, which is more porous and more, which has got more perfusion. So that's the difference as far as our system is concerned. That is corticobasal.
But is there any evidence that basal bone doesn't undergo osteoporosis? I mean, patients, do they have various densities of basal bone, or is there? I mean, because you can look at density of bone on a CT scan,
Yes.
looking at Hounsfield units.
You can. Yes, certainly.
There should be some studies on basal bone as well, looking at densities, and I think the densities of various patients tend to be different, as far as I know.
Yes, definitely. Based on Hounsfield units, you can definitely assess the density. There's no doubt. And certainly we have encountered difficulties when there is an osteoporotic situation in the patient. But what we generally do, we do a bit of over-engineering in such a situation. We had a couple of implants. For instance, in the normal course, when we place 8 to 10 implants in the upper jaw, we may place up to 12 implants. And we ensure that we engage the cortical bone, because once you engage the cortical bone, then there is very little remodeling happening there. That is what happens.
Anjan, if I may come in.
Girish, I think, that's what I was going to ask you actually. Girish, particularly about the mandible. Because we always assume that the mandible, is dense bone. I mean, what is have you faced any issues, with mandibular bone being, surprisingly osteoporotic or causing issues?
I look at the mandible and maxilla as the male and the female. The mandible is, a much stronger structure. It is much more robust, while the maxilla is very gentle and it needs a lot of tender loving care. Otherwise, it just completely gives it back to you. So I think there is a huge difference per se when we are talking about the maxilla and the mandible itself. Generally, the mandible is very, very robust, but still I would differ from what Prasanth was saying, that, osteoporosis affects every bone in the body. And of course, you have the alveolar bone, which is much more softer, but then the basal bone also is certainly affected. When we are talking about basal bone, people start thinking that conventional implantology is only done on, alveolar bone. We have always, let me clarify that, we've always gone into the basal bone. That is where we actually go in and get good primary stability. Whether it's in the anterior region of the mandible, we tend to go in much deeper. Similarly, when it's in the maxilla, the alveolar bone is so much softer. We always go into the nasal floor or into the pterygoid area. So this is all we are always looking at cortical plate, which has good primary stability.
That is corticobasal implantology, basically.
Well, Prasanth, we have always been doing it from the time Brennemark, came up with this.
Very true.
I don't know where this terminology came in. People started saying, "Oh my God, this is basal bone." Traditionally, also we have always placed. I mean, it's only a kind of.
I think, Prasanth, the biology remains the same.
Exactly.
You can have different systems.
No, absolutely, no doubt about it. I agree with you 100%. That's what happens in the case of Audon 4 as well. You're engaging the nasal floor, you're engaging the cortical bone. So automatically, and that's basically because the cortical bone is less reactive. It is there is less remodeling there because of less perfusion. So that is the main reason why it survives when you engage the basal cortical bone. I agree with you, 100%.
Guna, coming back to you, what about the zygoma? Do you have you faced issues where, the zygoma is osteoporotic and...
No, not really. The zygoma is probably a little more resistant to that change, remodeling. But mandible, certainly, I've had some really osteoporotic mandibles. And again, coming back to what Prasanth says, if you can have your spinal column and your, your jaw, your thigh bones and your femur and hip getting affected by osteoporosis, I don't think your basal bone is going to be any exception. I don't think you can classify that as as a support for any system which engages. And I think we should come away from these concepts of systems versus what is the real biology happening. The bone, if it's engaging cortical bone, that's exactly what Brennemark did in the mandible. He went through the lower cortex and engaged it. We used the zygoma cortex, we use nasal floor cortex, we use pterygoid cortical bone. So that's fine. I mean, every system can use it, but we should be a bit careful about thinking that basal bone will not get affected by osteoporosis.
Basal bone certainly gets affected, not that it will not get affected. But once you take support from the basal bone, you have a much better chance of survival. And that is the case with any system, not just basal implants, but with conventional implants as well. I agree, 100%.
Okay, yeah. So I guess the take home would be that, be careful, don't assume that, bone is of the same density. It can be different. And for immediate implantology, basically taking support of the basal cortical bone, is an advantage.
Just to add on this,
so let's come.
Sorry, Anjan. Can I comment on a few more things?
Sure.
On that?
Yeah.
I mean, we need to also differentiate between osteoporosis and also osteopenia. This is something which we also need to look at too. From, when we are doing, thousands of implants every day, I think that is something which we need to look at. And today we are in that age group of patients where, obviously the ages, the middle ages and probably the elderly people whom we are talking about. Now, there is also a lot of people who have also got vitamin D deficiency. And this is another thing which we need to really, really look at too, because almost 80 to 90% of our population has had vitamin D. And there is definitely some correlation between vitamin D deficiency and osteopenia. And that means that your bone density is slightly much more softer. And I think that is something which we need to start looking at. And before you start doing any implants, good idea to check the vitamin D. If it is low, correct it, because your predictability of success is going to be much, much better than in somebody who's, in the 4 or 5 levels when you can have it around 30 or 40.
Absolutely. Agree with you, Girish. 100%. No doubt about it. Yes.
Okay, so let's just move on to a case. So this is a patient that, we were talking about smoking. So here is a patient who's missing 2526. And you can see that the edentulous space, the OPG, there's about 6 mm bone height. I have got a CBC scan, but try to go through it would be a little difficult. So assume it's about 6 mm bone height. And he's a heavy smoker, 20 a day. So maybe if I could, ask, since Samir was talking about the grafting options, what would be your take on, what would be your treatment plan for a patient like this? Would it change because of the fact that the patient is a smoker? Samir?
Oh, sorry?
Yeah.
Yeah, I could hear that now. I was missing. Smoking does have an effect on the osseointegration. We all know that. There's a lot of literature which says the success rate is slightly less in these cases. Maybe in the tune of 5 to 7% we have a failure rate. We try to, in our practice, we try to tell our patients not to do that, but I really doubt that they listen to us. We have a mixed response with these patients where we have grafted these cases. I have no inhibition in grafting them, but I do take a well-informed consent and take one of their relatives also to sign that same consent so that they don't create ruxus later. The advantage which I get with grafting with them is that one, their sinus membrane is a little more thicker, and so it's slightly easy for me. And 6 mm with residual bone height, I'll still go with grafting options. I have no idea how to do basal implants, and I don't know how to.
And would you think of smoke cessation for these patients?
I do tell them, please come after 15 days, have a break from smoking for at least 15 days before you come for these procedures. Invariably they'll come and say that yes, we are staying away from smoking but I don't really think so, because we could smell them on the day of surgery also. That smoker's breath is always there. So
okay, so let me take
we do it.
Sankalp's missing from the discussion. So let me take Sankalp. Sankalp, you there? Sankalp?
Hello.
Sankalp, yeah. What would
Yes,
be your treatment plan for this patient? Would it be any different?
Yeah, of course, probably I may not like to go for grafting, just not because we are afraid of grafting, just because already we can see that some amount of bone is there, so we can manage it by anterior and posterior implant. And of course, somebody has rightly pointed out that this lower molar is also somewhere we have to take care of it. And because since patient is a heavy smoker, we don't know about the age also. So apart from the effect of smoking on the osseointegration or on the process of bone grafting, his other health factors also we may need to consider. How is his hypertension, or how is his easy on anticoagulant or something like cardiac problem, something like these things. Because whatever we were rightly talking about the methotrexate also, or other drugs also, see, it is not about the drugs effect specifically on the integration or the osseointegration. What are the systemic effect of those drugs, or what are the systemic effects of these habits which patient is going to have, and which can affect our surgery which can affect our surgery also. So if patient is having, if it is a heavy smoker, I may not like to go for a open or invasive procedure. Probably I may have a proper evaluation of his systemic condition, and then I may go for a conservative management like anterior and posterior implant like this.
So would you use short implants here, or would you get a short implant and a zygoma or a pterygoid? What would you do in your?
Probably one anterior tilted implant, sir, and one posterior pterygoid implant. Because lower arch, we don't have any more teeth here. So I think these two implants will be sufficient to give him a bridge.
Okay. So you would choose a graftless option.
Yes,
so
sir.
Prasanth, I think with the basal cortical implant philosophy, would it be any different for smokers?
Yeah, definitely. There is our strategy is different. Of course, we don't do grafting. We go in for total. Now, in this situation, from what I see in the X-ray, definitely it looks as though it is a full mouth rehab case, because
no, the other teeth are actually firm. The other teeth are firm.
The posteriors
there is
are bad.
Some periodontal disease.
Yeah, there's some periodontal disease. So what I'll prefer is to straight away go ahead and place extract and immediately do implants, smooth surface, and they engage the basal cortical bone. Because they are smooth surface, there is absolutely no problem with the smoking part, because even a certain amount of recession is not going to affect the implants in any way.
But Prasanth, this is a patient who doesn't want any teeth extracted. He's not consented for any.
But you see, the problem
is only the missing posterior teeth.
Okay.
So you would convince the patient to have teeth extracted, or?
No, I would see, now we are commenting on the basis of this OPG. I'll always prefer to make a CBCT, evaluate the bone around, and if the prognosis is poor, I will definitely educate him to undergo extractions in such a way that we are able to give him a proper prosthesis which will survive in the long run. Now, for instance, if we are to do implants in the left upper posterior alone with a supraerupting molar, which is also periodontally compromised, what is going to happen? The prosthesis will certainly fail, especially if you have very poor periodontal support on the other side, on the contralateral side. So you have to look at the case as a whole. You have to manage the entire occlusion, which is the most important. And if your occlusion is improper, then you are definitely, it's a prescription for failure. So I would rather prefer to comment on this case only after I see the CBCT. And then if the teeth are in a poor condition, I would definitely recommend removal and implantation. If required.
Girish or Guna, would you have anything to add to that?
Strategy, yeah, Anjan, my strategy is completely different. I mean, if he's a very heavy smoker, I would be very hesitant to do implants, first of all. Two reasons why I always say is, number one, in the initial kind of osseointegration, there is a higher chance that it might get rejected. That's number one. And the second is the long-term kind of outcome with implants. We know in smokers, there is going to be a significant amount of bone loss in the long term. So I would be very, very hesitant. If at all the patient says, I'm going to willing to take the risk, I will always say that, you know, success in a heavy smoker is probably only about 80 to 90%. Take very good consent and then go ahead with that. But still, my entire focus would be actually to help him to give up smoking. So I would actually put him onto a smoking cessation clinic, maybe even wait for 3 months and then probably see how he basically behaves and then take it on. But if he's a very heavy smoker, I would be very concerned, especially bone grafting. I wouldn't do. I've had quite a significant cases where we have had, you know, failure.
Yeah.
So I'm very concerned about
yeah. So this is, yeah. So just some evidence, you know, to add to that. This is what, you know, the evidence that actually implant failures, you know, are not, you know, that's so much of a concern. Early implant failures, you know, in smokers are higher. That's what, you know, this paper suggests. But there is no difference in the survival of rough surface implants in smokers or non-smokers. This is a paper from AOMSI. On the other hand, if you look at grafting, now grafting obviously, you know, your surgical exposure, the fact that you're using biomaterials, all of this, you know, probably adds greater risk. And there is, you know, higher risk of complications in smokers, 1/3 of which were major complications, basically losing the whole graft or the graft getting infected. So yeah, every additional surgical risk adds risk of complications, but not augmenting during implantation again carries its own risks.
Anjan, can I comment on this?
Yeah.
If you go back to the slide, the X-ray slide.
Okay.
X-ray.
Yeah. Okay.
Yeah. So definitely the smoking cessation will be important in this. We should at least give us 6 weeks, 1 month to 6 weeks time to the patient. He should stop the habit of smoking, and we can help him with the nicotine patches and all the counseling, things like that. Once these things are settled, because we have explained him nicely, for at least 2 months, he should be on the smoking cessation protocol after doing implants. If he is not ready for the extraction in other area and all the teeth are firm nicely, then if age of the patient is more, we can do indirect sinus lift here, and we can do short implants. As you said, the height is 6 millimeter. Definitely a 8 millimeter implant can be done here by doing an indirect sinus lift on this side. If you see a concept in basal, then even this side can be done with like a quadrant concept, 2 pterygoid this side and 2 implants this side. Even if it's required to remove on this first premolar, let that go out. So we can do a canine bypass and do 2 implants this side and 2 implants pterygoid, and we can rehabilitate him immediately if you want less trauma there. And it's because as it's a smooth surface. And once he will convince later, because now he's understood the importance and all that, in the lower the occlusion should be corrected or 1 single implant should be placed so that he has come for the bite and he should get the bite on the left side. So at least 1 more implant can be added in the lower immediately and he will get a good bite. If he's convinced later, then other side he will go for a good occlusal rehabilitation. That's what I think initially in this.
Yeah, and I think the evidence also, and I'll show some later on, that short implants actually are a fairly good option nowadays, especially if you're splinting short implants. There is, you know, we don't have long-term studies yet, but at least ND seem to suggest that implants of 6 millimeters splinted together do perform almost as well as, you know, grafted sinuses.
But I have a slight difference of opinion there, because see, as a smoker, certainly he's going to develop gingival recession if he continues smoking. Of course, you're supposed to ask him and you know, encourage him to stop smoking. But most of the smokers, they just don't stop. So if he continues smoking, most certainly the rough surface implant is going to get exposed. There will be gingival recession and resultant peri-implantitis, and you're definitely going to have a failure. That's what I have against short implants in such cases. But if the patient
we should move forward.
Yeah.
Okay.
I think
let me just complete, please. So, but if the patient has stopped smoking, then there is absolutely no problem. It should take up very well. This is my take on this.
Prasanth,
yeah, I think in today's day and age, I think we probably can't be paternalistic about these things. I don't think we can be paternalistic anymore, advising patients that, refusing implants or refusing or convincing patients to extract teeth. I don't know whether that would be
patient
acceptable.
Can start
really.
smoking also, sir.
Yeah. So we have to accept the risks. And I mean, I think from what we said, there are risks involved, whatever treatment we try to offer the patient. But you can reduce the risk. Yes, grafting significantly has higher risks. Graftless is possibly lower risk. And I guess probably a cast partial denture is probably the lowest risk for the patient. Okay, we'll continue to the next. This is about periodontal disease and diabetes. So this is a patient actually who came to me. She had some implants placed 5 years ago. She's a mother of a doctor, and was doing quite well. Had well-controlled diabetes at the time when these implants were placed, and then her son went through some family social problems, and there were some issues, and her diabetes went out of control. And I saw her 5 years later, and this is her state. And you can see she's got multiple implants failing here with significant periodontal disease. When she came, her diabetes was out of control. So his patients with history of previous periodontal disease and well-controlled diabetics, would that change your treatment plan? Would you carry on with the same treatment plan for diabetics with a history of periodontal disease? Or would it change your treatment plan for these patients? So maybe Sankalp, do you want to comment on that?
Sir, now the patient is having two problems. He is having a previous history of periodontal disease, and he is also suffering from diabetes. And now we have to take, as I already told, I am always worried about the systemic factor. Diabetes is, though it is well controlled, but it must be having its own systemic toll. So we have to, again, I will evaluate the patient pre-operatively very well, because diabetic patients are having so many systemic diseases, including cardiovascular and renal problems also. Once that is sorted out, then if you talk about the periodontal disease, though we have seen the literature also, you have been practicing also, in periodontal patient, implant survival may not be a problem, but the survival is a tricky word. Survival is that implant is not failing, but moving implant is not causing any problem. But the peri-implant mucositis or peri-implant bone loss or peri-implant inflammation can still happen. It has been seen in those patients who are previously having periodontitis preoperatively. So we have to take care that the prosthesis which you are going to give them should be like this, that they will be able to manage their periodontal health or peri-implant health, as well as they have to be taught well about the management of the peri-implant health. And then of course regular follow-up, because we see that many a times we forget after placing the implant, and most of the time patient also forget after placing the implant. They only come back once they have some problem or some symptoms. So we have to chart out the proper follow-up program in these type of cases.
Okay, can I bring Venkat in? Is Venkat there on Zoom? Venkat? Venkat, from a prosthodontic point of view, I wonder, these patients, should we be giving them overdentures? Because I always find that, maintenance is so much better with my overdenture patients as compared to the patients who have fixed prostheses, particularly cement retained prostheses. Do you think, modifying the prosthesis would, be an issue, which you would consider in diabetics with periodontal disease? I think, Venkat, your mic, you're not audible.
Hello.
Yeah,
hello.
We can hear you now. Yeah, we can hear you now.
Actually, I prefer a fixed removal process rather than going for a removable process. When option is there, you always have an option to remove it when required. So these kind of cases, instead of going for bone level bridge, I prefer to go for a tissue level kind of bridge with multi-units, whenever you require something or any complication occurs, or the hygiene is not proper, you always have a chance to remove it. So always if screw retain solutions, especially in this kind of smokers and diabetic patients, because we cannot place lot number of implants, so each implant a tooth. So definitely in the Pontic level, you can expect some kind of bone loss, especially in these compromised cases, and you need to have an option for relining. So a fixed removable screw retain solutions are always better for smokers and diabetics.
What about overdentures? What's your feeling about overdentures?
Overdentures, the hygiene maintenance is...
Or do you see the mechanical failures are...
Yeah, always overdentures. I used to have a lot of problems. I always prefer to go for a fixed solution instead of going for a removable solution, because all the advantages now are there, whatever overdentures are having, especially unless and until the patient wants labial fullness completely. Otherwise, all the advantages of overdentures are there in fixed removable solutions. Screw retain solutions are always better.
Anyone else has any comments on?
Yes, I have a comment, Dr. Anjan. Will you just permit me to share my screen? I'll just show you 3 slides. That is more than sufficient. Can I share my screen?
I think it will be difficult because Praveen would have to do it. If you could just explain
it will be difficult.
It will be difficult because then I could have shown you the x-rays of a patient whom I've managed with extreme periodontal disease. We routinely do immediate extraction implantation with basal implants. We anchor it in the basal bone and we get excellent results. We've got lots of cases. We've documented all of them. Everything is available with me. I can show you many of my cases now if you want. Extreme periodontal cases which cannot be solved with grafting, with any sort of solution, we were able to help them. And I've got lots of cases with me which are surviving perfectly well. The advantage here is that you're just engaging the basal cortical bone. You're not depending on the crestal bone at all. And there's absolutely no bone remodeling happening there. And even a slight amount of recession of the gingiva is not going to affect the patient in any way.
No,
you may have to modify the prosthesis. That's
I think the smooth surface definitely has an advantage, but I think but I think that cement prosthesis that you have on the single piece implants, I think, is an issue. And as I think Venkat mentioned, I think a screw retained prosthesis, if you have a multi-unit, and I think if you have a screw retained prosthesis, the retrievability, I think is a...
No, Dr. Anjan, I have a difference of opinion there.
The cement, yeah, I think the cement, I think there's enough evidence to say that cement, I don't know what Venkat's take is on the cement. Venkat, do you want to?
See, actually, even the abutments of two-piece abutments are smooth surface. It's not that you are having rough surface in the abutment level. But still we have plaque formation and calculus formation. The same thing would happen even for a smooth surface implants. At the tissue level I'm speaking about, and not below the gum level or the bone level.
Okay.
So the same thing still happens because we are concerned on this soft tissue, above the soft tissue level. This single piece implants do not have calculus. It will still have calculus deposits and
There will be calculus. There will be calculus, but it's not going to affect the stability of the implant in any way. And you can, by performing routine oral hygiene, you're able to maintain the hygiene very well. There is absolutely no problem. And the additional thing about the prosthesis part, nowadays we use metal composite prosthesis which can be recontoured without changing the prosthesis at all, which is a very big advantage. So what we do, we provide the prosthesis, and if at all over years there is a recession, because it's made of metal composite, you're able to adjust, add composite to recontour the prosthesis margins, and you get an excellent result. So we don't have to practically remove the prosthesis at all. We don't have to go for a second prosthesis.
Doing a composite externally in the laboratory itself is so difficult, polishing, and still you have a lot of porosity there. How could you expect by relining
we have documented all these cases.
I think we'll have to leave that as a matter of contention, and that
we have documented all this. We have all these cases with us.
Anjan, Anjan, at this point, I want one discussion from the senior panelists that sometimes, you know, even when we do implant in a healed site, the regular rough surface implant, And even we wait for 6 months, they just fail. You see a bone loss approximately up to 30 to 40 to 50% of the implant length. This should be discussed if it is possible. That why it happens.
Avi, I think those of us who are old enough to have seen machined Brannemark implants, I think even the machined Brannemark implants have also had the same sort of failures in healed bone. So I don't think it's to do just with the rough surface.
No, not
but
like
I think
why it
that's
happens.
something which we can carry on. I don't think it's about the surface only. I think there are multiple factors. But we're talking more about systemic factors here. So let's continue with that discussion.
Just to come back into the previous discussion.
So age.
I think we need to really look at the case which you showed earlier. And we've all come across these kind of scenarios where they've done extremely well for the first few years, and then they come back with severe peri-implantitis. And that's where we really need to look at so many factors. Number one is the fact that patient compliance in terms of hygiene maintenance. Number two is how many times do they come back for follow-ups? Unfortunately, in India, it's very rarely they come back. That's another big issue. The third thing is many a times we have seen that when you have a removable option, the hygiene maintenance is so much better, especially when you have a diabetic patient, and a medically compromised patient. They can actually maintain their hygiene much better. They can take the prosthesis out by themselves, clean around basically, whether it's an overdenture, a ball, or basically a bar. It's so much easier, and definitely we've seen better outcomes in that kind of patients. And my next point is, in our own practices, I would beg to differ from Prasanth that, there are so many patients who come to us who have already had their basal implants also done. And the biggest concern which I see is the fact that their hygiene is so bad. They smell so badly. There is so much of infection going around that. And I'm very much concerned many a times when I see these kind of with mobility of failure. So you do come across all kinds of patients who, I'm not saying, oh, it's, basal implants is probably a panacea, but I think in every case we do see failure. So I'm very keen that,
Girish, I have to comment on that. Anjan, just give me a moment.
Failure later on.
Yeah, let me just comment. Let me just answer his question.
Okay.
See, we also have, immediately, we also have multi-unit implants. For those of you who are not interested in having cemented options, we have multi-unit implants. And by using multi-unit implants, you can easily remove the bridge, do the hygiene and then do the maintenance and then put it back. That's very much easy. Screw it back. Now, as far as the periodontitis, the poor oral hygiene and stinking bridges are concerned, it's improperly fabricated or it has not been maintained properly, as you said right in the beginning. Maintenance is the most important. If the patient does not come back to you once in 6 months for proper maintenance and occlusal checks, you will certainly end up in a mess. There's no doubt.
Absolutely. So, that is with any system.
So I think let's just conclude.
With every system, yes, I agree.
And say that maintenance is very important. I think
absolutely.
I think we have to counsel our patients better and educate them that the fact that this is not a one-time solution where they can never visit the dentist again. They need to keep coming back.
Yeah, absolutely. Yeah.
Okay, so looking at age. So if I can just ask all of you, which is the youngest and which is the oldest patient that you have treated with implants? We can start.
My youngest is okay. Sorry, give the order. Anjan, you are the moderator.
Girish, you can start with
my youngest patient is a 12-year-old patient. Of course, it was because of a pathology, and from then on, I've been doing if there is a need in the younger age group too. So the youngest is 12, and the oldest is 92.
Okay,
and Prasanth, as long as the bone is good, the health of the patient is good, I don't see age as a major criteria.
In my situation, the youngest is 20 and the oldest is 93.
Okay.
I will prefer to do implants only after the growth is complete, always. That's my preference.
Okay, fine. Okay, Sankalp?
Oh, I had made a mistake, sir, placing an implant in a 9-year-old boy. 2 central incisors knocked off. So I took him under GA that time. I was very much highly overconfident. Placed 2 central incisors. A doctor's son. So implants are still surviving, but the prosthetics, if I show you, You can easily make out that some novice has done it. And
so did the implant get submerged or what happened?
Yes, sir. Implant got submerged and they are too close to each other now. Means there is no expansion also. So you can use both the central incisor are almost double the size of lateral now. So I recently changed the prosthesis also. Then I had certain other cases also. I placed another molar also in a 13-year-old boy. He recently visited. Now he is 17 years, but now you can make out that that molar is infraocclusion. And usually we think that the upper one will supra-erupt, but the upper one is because it is in contact with the another molar also in the lower side. So upper molar is not supra-erupting. So there is a gap. Now we have to change the prosthesis. So
Sankalp, what would be your youngest patient? What would be your youngest patient now on hindsight?
Now it is 16 years minimum.
16. Yes. Okay. Yeah.
Okay. And we have many choices. We have many methods to check the bone growth, sir. Now, after that, I have read a lot about the bone growth and methods to check bone growth. So we have to decide whether the bone growth has completed or not.
Okay. So the second part of the question was: is age a criteria in deciding the treatment option? And like Girish was saying that if the health is good, then it's not a contraindication. So just to so this is a patient who was missing a 2.5 and a 2.6. Would your treatment options be different for this patient based on whether the patient was 22 years old or 82 years old?
Absolutely.
Maybe we can start with Samir. Maybe let's.
Yes.
Samir,
yeah. So my youngest was like 18, and my oldest patient was 84, where I placed my implants. And as Sankalp has said, that there are a lot of prosthetic issues with placing implants in the younger patient. So treatment does change when it comes to young population and old age population. Like in this case, I would go for grafting for a guy who's young, but for old patients, I would go for a shorter implant, splint them. I'll be less invasive for the older population of our patients.
Okay, yeah. So Girish, you wanted to say something?
I mean, obviously there is a huge difference when we are talking about a young individual who's going to live for at least another 70 years or 80 years, who is a 22-year-old person. So I would actually, in such kind of cases, definitely think in terms of probably building up the bone, and putting a long-term kind of success. So I would be thinking definitely in terms of sinus lifts, whether it's an indirect or a direct, it doesn't matter. But then that is something. But in an elderly person with teeth like this, I wouldn't even consider doing implant, maybe just a simple bridge also, I mean, you would definitely think about what is the best option for an elderly person. So keep it as minimalistic as possible for the elderly person. But by and large, I think age, something we need to look at is definitely the best thing is for the growth to be over. Not that I'm saying that I'm doing in all children, definitely no. It's only depending on the circumstances. Sometimes when you think that the bone can be implanted and that the growth is still, that consideration has to be taken in. So I would definitely wait for the growth to complete, maybe 15 or 16 years, and then think about placing implants.
Prasanth, with the basal philosophy,
what I would do
what would be your
is
treatment plan for this patient?
Yeah, what I would do is I would do a tripoding. We will do a canine bypass, place an implant bypassing the canine root on the palatal aspect, place an implant to the mid-palatine suture, taking support from the palatal bone on the palatal aspect of the sinus, and then go for a zygoma on one side. A tripod there will help solve the problem there.
Okay, fine. So there are other options other than
zygoma
sinus.
also here. How would you do a zygoma here?
A zygoma.
Girish, there are more than one options. That's the whole.
Absolutely. I mean,
I mean,
I can answer him if.
But I mean, yes. I mean, if this patient had a sinus lift and it had failed, I would consider a graftless option, like as you say. Maybe even a zygoma. Yeah. Okay. So so this is just some evidence again to show that short implants are an option. And as Girish was saying, look at the patient as a whole, don't look at them as just an implant patient. a bridge may be the simplest solution for the patient. You don't even need to look at even short implants. But these are things that we need to consider when looking at our patients. So now we come to a few surgical options and socket preservation. So let's start with maybe Samir again.
Yeah.
What is your philosophy with socket preservation? What do you do if you're extracting a tooth and you're planning an implant? Do you do anything special?
No, I don't place any grafts or any socket preservation materials into the extraction socket. But if I want to heal, allow the socket to heal, I just wait for 6 weeks and then re-enter the socket. And in these 6 weeks, really doesn't, nothing much changes. But the advantage which I get is that soft tissue heals properly, and I'm able to place my implants in a more definitive manner, more predictable manner. So no, I don't use any graft materials into the socket anytime.
Okay, and I think Guna is back here as well. Guna, do you do anything particular for socket preservation?
I prefer socket preservation and a delayed procedure, because we are seeing, especially in the aesthetic zone, we are getting long-term better results are certainly seen with delayed procedure, not immediate grafting, immediate placement. So I would definitely socket preserve. It's for bone and for soft tissue, better aesthetics. And also, if you want to have a very good prosthetic position to allow you to do a guided surgery later on. While I'm there, Anjan, I'd like to quickly comment about the age group. My youngest patient is 5 years.
Yeah. Okay.
5 years old in a mandible. So ectodermal dysplasia patient, I really thought a lot before doing that patient. And then when I looked at the literature, there were quite a few, almost about 12 patients described with 3 years of age, 4 years, 5 years. But this was one patient who just could not keep his processes in. He had a complete denture. So we did on a 5-year-old, it's a 1-year follow-up now, 2 implants and an overdenture. So in the mandible, in syndromic cases, you could have options of doing it at a younger age. It's not a contraindication. But you can't do a fixed one. You have to have a removable because you have to allow for growth in the symphysial region. So just a comment because we didn't discuss about the lower stage. So in the mandible, yes, you can have some options.
Okay. So maybe we can just continue that discussion about asepsis and antibiotics. What is your protocol? And you can see a picture here. Is that how you're set up for every implant, or is your infection control any different? You give antibiotics, before, after? Guna?
For me, okay. Yes, the antiseptic asepsis control looks reasonably good there. And I would say antibiotic as a one-shot pre-op, I prefer to give Augmentin.
Okay. No, what I meant is
that pre-operative mouth rinse, a chlorhexidine, or a povidone iodine mouth rinse. I think that helps as much as antibiotic also.
What I meant is that level of asepsis required for every implant placement?
I think it's worth it.
Does the literature support it?
I am not aware of it.
Okay, I agree with Dr. Guna. I agree with Guna. That is a protocol I follow in my practice very much.
Okay. Okay. I know as surgeons, I think we all like asepsis. In fact, if you look at the literature, Dennis Tarnow in New York did a study, and he found that, doing the procedure as a clean procedure, instruments are autoclaved, but, not actually putting even sterile gloves on and placing the implant, and, doing it with, surgical, asepsis like in theaters, the success rate of the implants was similar. I mean, that may be different for grafting. I think that's what he put as a note there. But for conventional implantology, I think that level of asepsis, is questionable.
Can I interfere, sir?
But I know as surgeons, yeah, Sankalp.
Actually, sir, it's a question of becoming a habit, sir. Once you are habitual of using or doing an implant as a clean surgery, you and your staff become habitual of that, sir. Then if you expect in some grafting cases or some challenging cases that they will try to maintain or they will be able to maintain the asepsis, then it's become very difficult. So to break that mindset of sir.
I fully agree with that.
So it is good to have a protocol.
Yes,
I agree. And I think I would do the same. I maintain, the same sort of asepsis. This is just the evidence I put in to be the devil's advocate. But to change protocols and saying, this is okay for this patient and not for this, especially in the COVID era, where I think our asepsis protocol is probably going to be even more stringent than this in the future, maybe.
Absolutely.
I think.
Absolutely.
I think we need to have very
we have to consider it.
Yes.
Yeah, absolutely. I think as good as any OT standard we should. I mean, this is a surgical procedure. And I think the message should be very, very bold and clear that it needs to be extremely in a very, very careful, sterile environment, which we are doing. So we cannot compromise on that. I mean, God forbid, if you have a rejection, then probably you'll be blamed for the fact that you're not maintaining a good operatory. So I think it's very, very important that we have a very good, sterile, dedicated operatory exclusively for implants and not do it in places where you're doing routine dentistry. That's what I advise everybody.
Yeah. I'm sure all of us will agree on one point. We escape very often because of the high perfusion in the orofacial region. That is the reason why most cases, they don't get infected at all. But that doesn't mean that you shouldn't take precautions. The precautions, definitely they are mandatory and they should be set in as protocols, certainly.
So coming to the third one, flapless versus flap surgery. So Girish, what is your protocol?
Yeah, I mean, it all depends on the
place your implants.
Scenario. Yeah, if it is abundant amount of bone, A type of bone, I always would like to prefer to do a flapless procedure. But if it is compromised in any way, you are wanting to do another additional procedure, it's much, much better to open the flap, see what you're seeing, see how the bed is, maybe do a bit of preparation, and you have an opportunity to do even grafting or putting a membrane or whatever it is. So everything depends on the volume of bone which you have. So if you have good volume, my take is basically you can do and get away with flapless procedures. But if in doubt, please open, because in surgery, you can actually have better opportunity to bring in an additional procedure when you open a flap. That's my take on it.
Okay, so coming to Guna, I mean, you have all the tools, you have guided surgery, you have a CBCT in-house. So do you always, use a stent and do your flapless surgery, or would you do it freehand, or do you always raise a flap?
Today, I prefer more and more with a stent, not because from the surgery point of view, but to get my, the position of my prosthetic screw and the, you can be so wrong by just going a millimeter or two away. Look at the aesthetic zone. If you have your central implant or a lateral incisor implant just a millimeter away or just about 5 degrees off what we think is an ideal position, you could have long-term problems with the processes. So today we have the tools available. You've got a cone beam CT available in a lot of places. You've got easy access to making surgical stents. So when you have that technology, of course, more than 50% of the time, you may not be able to do a fully guided surgery because a lot of times we need some grafting. So I would modify and say I would use a stent, but largely as a semi-guided procedure. I will use it for my first pilot drill. And if necessary, if I have to do a grafting or some soft tissue augmentation, I would flap it. I would open the flap, place the implant, do the grafting and close it. But so the stent is for very precise positioning, a buccolingual, mesodistal, and the more important also the depth of placement. A lot of times we get caught by not placing the implant as the proper depth to get proper emergence profile for your processes. So for these three positioning, the three-dimensional positioning, I think a stent is definitely very useful. And today, my stent usage is increasing simply because we have access to all technology.
Prasanth, your implants, I know, placed mostly, flapless.
Yes.
Do you do them with a stent, with freehand?
No, I don't use a stent at all. It's always freehand. 95% of my cases are flapless. Just 5% are with a flap. And we do have an in-house CBCT. We do make a proper evaluation with a CBCT, and if required, we also make stereolithographic models to study the bone contour, and then we go for a freehand surgery. And the biggest advantage here is that, you know, when you penetrate the first cortical, go through the porous cancellous bone, and then you hit the cortical, the second cortical or the third, you exactly know the depth of the cortical, and based on that, we are able to take the length of the implant and engage the basal cortical bone. So there is no question. I mean, me personally, I don't wish to use a stent, but there are doctors who are using stents in our discipline as well.
And is that because you can then bend the abutment to correct the prosthetics?
Absolutely, absolutely, absolutely. We are able to bend. But as Dr. Guna was mentioning, if you can also think of using it just for the pilot drill in order to get the position right. For all the beginners in basal implantology, they can always do that. There is no problem. To get the position, the angulation right, and to reach the cortical, you can use the pilot drill with a stent, then remove the stent and straight away screw in the implant after you've done with a twist drill. That's possible. But me personally, I don't use a stent at all.
So we'll come to the next question, and I like to ask Sankalp.
Yes, sir.
Delayed versus immediate implants. What's your preference? Do you place most of your implants delayed or mostly immediate?
And Dr. Anjan, just one more point. I forgot to mention another point. There's a phenomenon called the RAP phenomenon. That is a regional acceleratory phenomenon. What happens when you open a flap, you're always going to induce some amount of bone resorption there at the surgical site over a period of time. But when you go for a conservative procedure, when you don't open a flap, then the RAP phenomenon is considerably lower, and that definitely helps the patient, and the post-operative edema and the remodeling is minimal. And the other very important point is that now we are in the COVID era. We cannot afford to do very complicated procedures on patients. So it's always better that we try to switch over to flapless options whenever possible. Thank you.
Okay, coming back to Sankalp,
Yes,
delayed versus immediate. What's your preference?
Sir, depending on the case, sir, if it is a single tooth case, anywhere in any quadrant of the mouth, whether it is anterior or posterior, if I'm extracting it, most of the time I'm going to do it, or my plan is most of the time to place immediate implant. Not only immediate implant, as well as immediate loading, if it is a single tooth case. And then if it is a full arch case, then in mandible, of course, it is not a question. Mandible, of course, I am very confident about loading it immediately. If it is a fully edentulous case, then mandible as well as maxilla also I prefer to load immediately. But if it is only maxilla is edentulous and the mandible is having natural teeth, or mandible is having some sort of restoration with the implant, then I am most of the time I am very worried, and probably still I may like to give an immediate prosthesis, but I always keep my fingers crossed with most of the failures I have with this maxilla immediate loading. So I'm not confident that I may like to go for a removable prosthesis or something like extra implants and otherwise most of the time immediate loading.
Okay. I used to be like you. I used to do a lot of immediate placements, and then I think going back to them, I started looking at them and found that prosthetically they're not always in the right place. And Guna, I'd like to your take on that. I mean, I do much less now than I used to of immediate placement, just from the fact that I think long term, I'm not happy with the prosthetic results sometimes.
Okay, full arch. Always try to do immediate placement, immediate loading. Full arch. Single tooth, aesthetic zone. Yes, I've shared your experience. I've also get more problems with immediate placement. Again, not from the surgical part, from the prosthetic and the aesthetic part. And today we know there's a consensus statement from the ITI. ITI consensus statement has changed, and they say, look at the aesthetic zone and upper anterior aesthetic zone. Please do not place immediate implant. There is the consensus statement. They go through a green, yellow, and red sort of categorization. And that's come through a really big study. So I think we should be a bit careful in the aesthetic zone. All other areas, you can place immediate placement with or without graft. Maxilla, I would be careful about immediate loading, single tooth implants. If I have two, I'll splint and load. Single tooth, I will not do immediate load in the maxilla. Mandible, single tooth, if I get the primary stability of 35, I would definitely load.
Okay. The next one was loading and graft. I'll ask Samir that. If you're grafting a patient, would you load the implant?
So that depends how much grafting I'm doing. If it's for 1 or 2 threads, in fact, maybe till 25% of my implant surface is getting grafted, then I would go with provisionalization. But if it's a complete big grafting, then I don't go for immediate provisionalization. And as you have already shown in your slide that I try and give a provisional only if I get a 35 NCM insertion torque. But other than that, anything less than 35, I don't go for provisionalization.
Girish, what's your take? Loading and grafting? Do you?
Generally, I don't load it immediately after grafting. I'm a bit more conservative. I wait maybe 3 months, maybe 6 months, and then only I load it. I mean, unless it's in, again, it's, I think all these things, we all agree that it is all patient-centric. And sometimes you're pushed for, when the patient's really concerned about the fact that they want aesthetics, they want, an immediate prosthesis. Many times we may have to succumb to that. But otherwise, given a choice, I would, whenever I graft, I would wait, for a minimum period of 3 months and then load in.
Okay. So Prasanth, I'm not very familiar with the basic technique, but do you have a torque wrench? Do you look at torques when you're placing basal implant?
We don't use a torque wrench, but generally the torque, I mean, for all the beginners, you can always use a torque wrench. And we see that the torque is somewhere around 60 to 80. It should be around 60 to 80 in the normal course. And coming to the immediate load part, we always do immediate loading and we don't do grafting at all. Whether it be anterior or posterior segments, we always do immediate loading. And especially these days where people don't have time, and in the COVID era again, immediate loading should be adopted. This is my belief.
Okay, so I'd like to discuss another scenario with all of you. This was a 40-year-old female patient who had come to me for having a tooth replaced. The extraction had been done 3 months ago, and we did a CVCT. The socket healed quite nicely. We placed the implant. It looked like D3 bone. We got a good torque. The only thing in the history was she said that she had a history of metal allergies, and she couldn't come back for a few weeks. She was working, and then she sent me a picture saying there's something not quite right, and this implant, is exposed. And this was an implant which was, seemed to be textbooks placed, and the implant was extruded out of the socket. And I mean, she insisted that she wanted to get allergy testing, and she did have allergies to multiple metals when she was tested by our dermatologist. So I'd like to ask you, I mean, does titanium allergy, or does the immunology to titanium play a role in the success or failures of our implants? Have you had any issues, patients with cluster failures of implants where there's no known cause, they're otherwise fit and well? Anyone have this sort of experience?
Anjan, did she have any kind of urticaria or any mucositis or any other rashes on the skin or anything like that?
Yeah, she would break out into rashes with lots of things, medications, and even, certain types of, things like, seafood. She had issues with those as well. So she was, a slightly atopic person.
I've had only one patient who has told me in my career that she was allergic to, specifically she said she was allergic.
I never believed it until I had this experience.
This is a lady who had come from Bulgaria, and it's an international patient. And she said, I'm allergic. So I said, oh, in that case, can we think about zirconia implants? And, we were looking at that kind of scenario. But, I too looked up in the literature. There are quite a few actually, cases where we have had people talking about titanium allergy in the orthopedic literature as well as in our literature. So I think there is allergy to anything and everything. We have had people having allergic to, peanuts and whatnot, like betadine, and I think even to titanium. So it's very less and very rare, but yes, there are people who have had these kind of reactions. So I think that is something which we need to ask in our history too. It could be that she's allergic?
I have had a similar chance where I had placed 3 implants in the mandibular interior region. That was in 2003 when I just started my implantology career, and this was my second case. And after 24 hours of my implant placement, she said, ever since I got the implant done, I'm having difficulty in breathing. Though there was no sign of any rashes or anything like that, I tried to pacify her. Maybe I thought she's overreacting to the surgery. She was a very, very delicate kind of patient. But so next morning, I actually removed all these 3 implants, and she felt okay. And we ultimately landed up giving her a zirconia bridge later on. So I'm not sure that she was allergic to titanium that time. She was actually misguided by one of fellow colleagues also that time. But yes, I have had similar kind of problems in once.
Okay. Anyone else? Any comments on that?
Why don't you consider a patch test in such situations?
Well,
if a patient,
if you look at this paper, Prasanth, I looked this up, and they say that the patch test is not actually reliable.
Not reliable.
The diagnosis, it doesn't give you.
Reliable.
Yeah, but I think it's worth looking at this paper, because coming from Thomas Albrechtsen, I think it's a very well-written paper, and he says that people do have immunological. We always take osseodegradation for granted, I think.
Absolutely.
Or osteofixation maybe. We think that titanium is a very noble metal, and it's very well bio-inert, but people do have immune reactions, and that's what this paper discusses, and we need to.
It's like local anesthesia.
I think that's the first part. That
I mean, Anjan, how many of us actually even test for local anesthesia in our practices? I mean, you look at the medical side, almost everybody actually gives a test dose, and then they actually do it. So, it's a kind of, as dentists, we take even local anesthesia very, very casually. So you
Girish,
do come across
something, Girish, there was an anesthetist friend of mine who was saying, by giving a test dose, that itself can work out to be a sensitizing dose.
Yeah, absolutely.
So that can work out to be a sensitizing dose. So how do you justify that?
Yeah,
again,
So Avi, are you there? Are there any questions from the
no.
audience?
No.
Is there anything which we have not covered, which anyone wants nothing there?
Nothing.
So
Quick
should
comment.
we move on to the Guna, you wanted to say something?
Yeah, I think you hit the emphasis on the history. That is very critical to be prepared. If there's an allergy for metal, there's a very high chance that they can also react to titanium. If not titanium implant, they can react more even to the abutment. Anything with titanium nitride is actually more allergic. And one, of course, test is to do a skin patch test. Otherwise, is to do your the serum Melissa test. I think that's becoming a little more as a standard test. If you have a suspicion, do a Melissa test before you do the implant.
So then we'll move on to the next section, which is a few case scenarios that I've picked out. So here is a patient, is 50 years old, he's otherwise fit and well. He's got a failing bridge 24 to 26. I'll show you the after extraction, that's the residual bone there. And what would be the treatment options? So Samir, I think it's fairly straightforward case, hopefully, but you do simultaneous, do you do indirect, do you do direct? You can just tell me what your...
Direct for sure, direct sinus lift for sure in this case, because anyway, the remaining dentition is pretty okay. I don't have to extract them and do anything. So I'll do a direct sinus lift, wait for 4 to 5 months, and then come back and put implants. But definitely a staged procedure, not putting implants simultaneously, because I don't think so there's more than 2 millimeters of bone hair, residual bone height here. So I would go with the direct sinus lift.
What is your ideal mix? What is your ideal mix of graft?
So in this case, since the bone height is less than...
Not mixing an implant.
Hello? Yeah, can you hear me? Yeah, so in this case where the bone height is 1 to 2 millimeters, I'll definitely mix my allograft or xenograft with autogenous bone. I'll try and harvest it, one from the window, which I'm going to create, or second from the retromolar area as well. I'm going to mix it with the autogenous bone and then do the graft. It's not going to be a xeno or allograft alone. Yeah.
Okay. Girish, would you do anything
Yeah,
different?
I mean, I agree with Samir. My line of treatment also would be a direct sinus lift. Again, a combination of autogenous, maybe a synthetic graft material or a bovine bone with PRF, and wait for about 4 to 5 months or even up to 6 months. And then once get a CT, if the bone is good, then probably go in for 2 anterior implants and maybe a pterygoid, 2 or 3 anterior and a pterygoid implant. That would be my line of treatment for this.
Okay. And Prasanth, what would be your line of treatment? Anything?
I'll prefer to go for a canine bypass in that area, place an implant bypassing the canine, and place one more implant and in the anterior region of the sinus towards the palate, maybe engaging the mid-palatine suture, going for double pterygoids in the posterior. And if we are able to get excellent anchorage with these implants, then that's enough. If not, we may have to put in one zygomo as well. And we complete the case. Now, the most important thing here is, it is not enough if we just do the left upper jaw. It's important that we rehabilitate the left lower jaw as well, the third quadrant, because otherwise we will not be able to give optimal loading to the prosthesis, which is crucial because we are supposed to give it optimal loading for it to really survive in the long run.
Okay. So I think that's a very straightforward case. So we'll move on. Okay. So this is next patient. So this is a 60-year-old gentleman who came to us edentulous, having had teeth taken out 4 months ago, and he had never worn a denture. He was a little anxious about wearing a denture, wanted to look at what the fixed options for replacement would be. I have got the whole CBCT with me, but I've just put on one on the screen there. I hope that gives you, I mean, what you can see on the cross section is pretty much the width of the bone all the way around from premolar to premolar. So just going over the treatment options for this patient, maybe you can start with Sankalp. What would be your treatment option for this? And this patient has been edentulous for 4 months. Would you always immediately load this, Sankalp? Are you there?
Sir, hello, audible, sir? Hello?
Yeah. Yes, yeah.
Yes, sir.
Yeah.
Now, again, sir, this looking at the CBCT, sir, in the upper arch, of course, I would like to go for tilted implants, probably 4 implants between the maxillary antrum and 2 pterygoids implant. On the left side, it looks like the distance between the distal implants and the pterygoid will be probably too much. So we may put a zygoma if needed. And in the lower, of course, either lower CBCT is not there. So either if we can place 6 straight implant or 4 tilted implant, depending on the bone available posterior to mental foramen. Again, as I said, sir, regarding the immediate loading, since both of these are edentulous, so I may go for immediate loading provisional also. If I get a good primary stability, I'm confident. Otherwise, it is not necessary also. So I don't promise.
So
I tell them side only
okay.
in the chair.
Depending on how the surgery goes.
Yes.
Okay. Yeah. Girish, any difference?
Mine, I think probably I would just rehabilitate only in the anterior zone. So it's probably my choice would be all on 4 in the maxilla. Maybe just a simple trefoil on the lower. That's my take on this one. I probably would not consider a pterygoid just because it's 60. I think probably just anterior all on 4 should be good enough with 12 teeth on the top.
Okay. And if I can, from a positive point of view, you can just bring Venkat into the discussion. I mean, some of these patients, sometimes demand ceramic, zirconia, they want better aesthetics. I mean, if you were doing all on 4 upper and lower, like Sankalp or Girish mentioned, would you consider giving them ceramic, or would you prefer acrylic? Or
in this case, if you see on the left side, I don't think we can give even 10 teeth considering the sinus pneumatization. Probably on the left side, maximum what we can do is place till the first premolar because there's long space. And when you're thinking about a cantilever, always you need to have a rigid body because first thing what starts is with the prosthetic failure. So the processes should always be rigid. If you're thinking about having a long cantilever or something like that, if you're thinking about all on four, always I prefer to go for a kind of mallow bridge. Otherwise, if as Dr. Sankalp was speaking about going for pterygoids, because in this CBCT, you may feel that the bone is not there, but definitely the bone will be there in the pterygoids, and you can think about going for posterior implants when you're going without a cantilever, because most important is the Anti's law, because when there's a lot of flexure, there could be a kind of movements, micro movements, which starts with the prosthetic screw loosening and then breakages. So always rigid prosthesis, which is screw retained. I think a Columbus bridge would be a good option. Then if you're thinking about cantilever, always you should think about either a hybrid bridge or a mallow bridge.
Okay. And what do you think about, ceramic in one arch or zirconia in one arch and acrylic in the other?
Zirconia for full mouth rehabilitation, I say no, because the connector strength is really bad. But yes, if it is a screw retained solutions for PFM or hybrid, you always have a little flexure, which will prevent, and acrylic is also a good space for the force dissipation. Thinking about acrylic, especially long span bridges, metal acrylic is also a good solution. Zirconia, I don't recommend, especially in these kind of places when there's a lot of pontics, there can be connector breakages.
Anjan, can I just raise one
Prasanth,
question here?
Yeah.
Okay.
Can I speak now?
Can I?
Sure, yeah. Who was that? Avi, or who was that?
Avi, can I raise a question?
Avi,
Yeah. See, we are coming.
Avi, I think.
Yeah, see, we are facing one problem with the acrylic bridges, the metal fused to acrylic, that, the force increases, the mastication force increases, and the patient chews very nicely. So the posterior teeth are treated. And then that leads to the shift of the force anteriorly. And that causes the popping out of the teeth. So personally, I have stopped doing now acrylic, and for past 2 years, I am doing all my cases with metal fused to ceramic. And with that, all these problems I am not facing. If any other things can be added into this or into my decision, please add into this.
Yeah, metal fused to acrylic is the best option, because in case even if the ceramic gets chipped off, you have a low fusing ceramics, correction ceramics you can add it always. You have a correction ceramics. But in acrylic, you always it's a little whatever you are adding, probably it will not be the same as what you have given in the first time, because definitely there will be some space at the porosities. I don't think you can maintain hygiene with acrylics. I also prefer always a metal ceramic when compared to hybrid. And mallow is also a good option if in case any one tooth gets spoiled, you can replace it. Yeah.
Okay, so Prasanth, what would be your...
Yeah, I would prefer 6 implants in the intersinus region, 3 implants each on either side, and then go for 2 pterygoids, double pterygoids on each side, and then go for a metal composite bridge. And of course, the loading is extremely important. The opposing jaw should also be completed following all the protocols. And in case the pterygoids, if we are not really getting proper pterygoids, then we'll have to consider the zygoma as well. That's my plan, and we do immediate load.
So coming to Guna, Guna, if this patient were to walk into your clinic, would you straight away say zygomas and anterior implants, or would you consider all on 4?
Certainly, we have to look at the dimensions. From what I can see, you've got a lot of bone loss in the first in the 1.4, 1.3, 1.4 region. So I really don't know what is the width of bone available. So giving if I'm
it's I mean I have got DTX Studio open, but it'll take a while to try to open it up. So
okay,
yeah, the width is about similar to what you can see on the most of the section and
if there's adequate width, certainly I will go with an all-on-4 for upper and for lower. And my preference would be for a ceramic bridge in the upper and an acrylic on the lower. Like Venkat said, a Malo bridge. And I understand Avi is concerned about the acrylic getting worn out and the bite getting changed. I think that's where I think regular reviews are very important. And that is where I think the initial planning is also very important, that you get enough space for your components and enough thickness of acrylic. If you do not have enough space for your acrylic, you will have more and more issues of breakages and component fractures and acrylic chipping. And so you need to allow that proper planning for space. If you need acrylic, you certainly need more space. And then that's why you need to have a follow-up every year. And that is also one of the reasons why a screw retained full arch solution is any day better than a cemented option.
Okay, I think we'll move on for time reasons. So this is a slightly young patient, 36 years old, executive. He works for at the airport in Bangalore locally. He has these multiple failing bridges, and he wants some solution where he can't go without teeth. His issue is I need to be back in the office after the weekend, and with something which fix that I can have. What would be? I've got his CBCT as well. Now, again, if these the CBCT wasn't great, there was a lot of artifact on it, but if I can just read out, he had quite poor bone from canine to canine, and if you see, the sinuses are very, very pneumatized all the way from the root of the canine forwards on both sides. So what would be your treatment options for this of a patient? He wants something with which he can function immediately. And again, maybe starting with Guna, since you're there, what would be your option for this patient?
I think this patient, you've got so much of periapical bone loss even in the existing teeth. So by the time you remove those teeth and clean up, curettage, you will be left with very little bone even in zone 1. So this will, to my eyes, I think this will become quad zygoma, double zygoma on either side. And once you get primary stability, you can go with the fixed provisional processes quickly. It is possible. And today we have data showing that if you have implants, zygoma implants with good stability, immediate loading has far better long-term results than delayed loading. So very interesting data that's come out that immediate loading is superior to delayed loading in zygoma implants. So that will be my treatment option.
Okay. And Sankalp, what would be treatment option for this patient?
Of course, zygoma will always be there, but I would like to see if anteriorly if I can place some axial implant. If even if 2 axial implants are possible, then my choice will be 2 axial implants, then 2 zygoma and 2 pterygoids. And then if I am able to place 2 zygoma and 2 pterygoids, then I'm very much confident about immediate loading. So of course, as in my lecture also, you asked me, first I'll place 2 pterygoids because that will be the most difficult one, then 2 axial implants, and then after that 2 zygoma. So 6 to 8 implants I would like to place in maxilla.
Okay. And this difference in the treatment option, would it be to do, you do most of your zygomas under local, I think, Sankalp, correct?
Yes, sir.
Yeah. Well, I think Guna, you do most of your zygomas under GA.
Quad zygoma under general anesthesia. Single zygomas we can do under local with sedation or even under local anesthesia. Once you get the experience, you can certainly do under local anesthesia with extra sinus techniques. But quad zygoma, I definitely
would be
general anesthesia.
Okay. Okay. Prasanth, what would be your options for this patient?
I would prefer a full upper jaw rehabilitation with 6 implants in the anterior region, anterior to the sinuses, and go for pterygoids and if required, zygoma as well. That'll be the plan. But it's extremely important that you compensate the lower jaw as well, because the lower jaw is also very bad. So we've got to ensure that the occlusion is proper, which is very, very important. So the occlusal scheme should be corrected in the lower jaw, and then do the upper jaw properly, taking support from the zygoma, pterygoids, and the anteriors. That's it. Immediate load. That's the solution which I'll offer.
Okay.
Can I say one thing, sir?
Okay.
Yeah. But can you see, sir,
Yeah,
now
Sankalp.
interesting it has become, sir. We are always worried about posterior maxilla. So all of the speakers are, nobody is worried about the posterior maxilla. Everybody is confident that posteriorly we can place either pterygoid or zygoma. So most of the time, sir, it is in atrophic maxilla. It is the anterior maxilla which is a problematic, sir. Whether we will be able to place the implant or not.
And in fact,
absolutely.
Yeah, I was going to ask Guna about that. I mean, how when you're doing a quad in a case like this, how anterior would you want to bring your anterior zygoma? Would you bring it to the lateral or canine? Where would you want it to be at least?
First choice is canine. Canine is the first choice, but you can come up with the lateral. Canine and the lateral are the 2 options.
Okay, so next case. So this is again a 50-year-old lady who has been wearing a denture, long-standing denture wearer, and she wants a fixed option. And again, I haven't put up the CBCT, but she anteriorly had a 2 millimeter width maxilla and an 8 mm height maxilla there. So what would be your options for this patient? Maybe we can start with Samir. I mean, starting with, if this patient was prepared for grafting, would you do something different, Samir?
Yeah, so lower arch seems to be pretty straightforward. Go for 6 straight implant. Macula, I think since she's 50 years old only, and we can try and go for grafting options as well. What width did you say in the interior max?
So it's a 2 millimeter width
Anjan?
and 8 mm height. So it's basically, it's like a thin shelf of bone, 8 millimeters height and 2 millimeters width. Not enough to place an implant.
Yeah.
Not a conventional implant, at least.
Which would require block grafting anyway in the maxillary arch if she's ready to go for grafting options. But if she's not going for grafting options, then zygomas are the options, which we can try it out.
What about the posterior maxilla? Would you do sinus lifts as well, or?
So if I'm going for block grafting anyway, then I will go for posterior sinus lift as well. But if she's not opting for any grafting options, then straight away you can jump for zygoma options, because it's only 2 millimeters. You can't do otherwise.
Yeah. So with the fact that it's 2 millimeters, you're worried that the regenerative power of the sinus is not sufficient. Is that what you're saying?
I think even if you want to expand it with some expanders or denser, you still need 3 or 4 millimeters of bone. If you only have 2 millimeters of bone, you will definitely go for block grafting. It's like Corey's technique or typical conventional block graft. And now to rehab a complete maxilla with block grafts, I think iliac is the choice, because if I can't take bone from the symphysis, because I have to place some implants there as well. And if I'm taking bone from iliac, I might open up the sinus and fill it with autogenous graft, and then I can come and place more, longer implants, since the patient is 50-year-old. Yeah.
Okay, Girish.
Yeah.
Girish.
So
so what would be your treatment for this patient?
Yeah. She's just 50. I think 50 is very young age. So we are all, 50. So I think probably we still have a long way to live, I think. So I would look at long-term solutions. My take on this would be, I think there is okay bone in the pterygoid region from what I can see on the OPG, of course, a CBCT to confirm that. There's really virtually no bone in the sinus, extremely thin bone in the anterior zone. So I would look at 2 pterygoid implants if it is possible, maybe 2 or quad zygoma. And also at the same time, I would take some bone from the ramus and then graft the anterior. If we're doing it under GA, then I would graft it so that I have some kind of insurance to get that thickness in the anterior zone. And later on, once that has got completely, the ridge is formed well in the anterior zone, maybe add a couple more of implants in the anterior so you have a full arch is what I would look at. So definitely zygoma, maybe pterygoid, and definitely bone graft in the anterior zone also, so that we have a contingency to take on more implants in the anterior zone. It's just 2 millimeters, but the height is good there.
So at least 6 implants is what you would want.
6 implants is what I would like to have.
Spread.
Correct.
Prasanth, what would be your?
Yeah, see,
Prasanth?
You have mentioned that it is 8 mm height in the anterior region. Now that's based on your CBCT imaging, right? Am I correct?
Yes, it's on CBCT imaging.
It's on CBCT. Now, what happens on the CBCT when you take a different angulation, when you're going to tilt your implant, tilt your drill more angulated, you will definitely get longer area to place the implant. So in my experience, what I've noticed, whenever the radiologist gives me a report of 8 mm height, very often when we drill in, we see that we get easily 12 to 14 mm sometimes. Even if it is 8 mm, we have options to place 8 mm height implants, but most certainly we will be able to place much longer implants when you tilt the implants, in the posterior around say 45 degrees, and then bend them. So then what happens, you're able to engage the palatal cortical and then bend the implant in the anterior region, and we are able to place 6 implants anterior to the sinuses, and then go for pterygoids, and if required, go for zygoma. That's how it will be. And the lower jaw, definitely the full occlusal scheme should be followed. You have to give proper loading in the lower jaw and complete the case. That's it. That's my plan.
Okay. Guna, what would be your option? I mean, would this be a case for a quad zygoma straight away?
I would
consider other options?
My things will certainly be towards zygoma rather than pterygoids. I explained this also earlier before, because in a zygoma, I'm seeing what I'm doing. In a pterygoid, I can't see what I'm doing. So for me, that's very important. And the second thing is, my concern is about this patient wearing a denture for a long time. If she's been a long-term denture wearer, I'll be very careful about converting into a fixed one. Because a lot of patients I've seen, they've been comfortable with removable processes, suddenly give them a fixed option, they're actually not very happy. From a variety of views, from hygiene point of view, from speech point of view. So I will discuss that very, very clearly with the patient. And if the patient still, because you got 8 millimeter height, you can certainly go for grafts, block graft. And I would also look at the option of using cadaver bone, because you get pretty good allografts today. You can use block grafts and for the anterior region, and then sinus lifts, and then wait and do, if possible, 6 axial implants and delay load it. But if the patient wants something, if the patient is okay with the fixed option, then definitely quad zygoma will be the option in this situation.
Okay.
There is also another option. After placing the implants, we can always splint the implants together with a metal frame and go for an overdenture option. That is also possible. That's something which we provide.
In fact, that's what I was going to ask Venkat about that.
Yeah.
See, this, I wish I had the picture of the patient. I didn't put them in, but this patient did have a bit of lip collapse because the anterior maxilla was quite resorbed. And if you want to give the patient lip fullness, without using an overdenture, giving a fixed option, can you achieve that, or is it limited what you can do with lip fullness?
Yeah, lip fullness, probably this case looks more like a combination syndrome because she has lower teeth and there's no upper tooth. It's more like a lot of pseudo class 3 kind of case where you see a lot of, you cannot get it so much anteriorly. You need to have a flange for these kind of cases. So in these kind of cases, it's better to have a flange with overdenture. I prefer to do a flange kind of dentures, especially in this. But if it is a male patient with mustache and everything, then I think a fixed removable multi-unit level, tissue level process is also a good option.
Yeah.
And
with sufficient number of implants, sorry,
yes?
I was saying, with sufficient number of implants, you could probably make the overdenture almost as stable as a fixed, right? I mean,
absolutely.
And the patient can remove it for cleaning. Yeah, that's the advantage.
Yeah, absolutely.
Yeah. Okay, good point. Okay, coming to the last patient, and this is a 22-year-old with severe periodontitis, and as you know, often they will ignore the disease until the patient is of marriageable age, and then they come with this sort of a scenario where this girl has only got 6 millimeters of bone, and we now need to rehabilitate her. And she's a very young patient. So Guna, can I ask you, what would be your treatment option for a young patient like this? Would you still go graftless or?
See, when there's severe periodontal disease, I'm always worried because, we know that even if you get rid of all the teeth and you wait for some time, the periodontal pathogens can still reside in different parts. They can stay in your tonsillar crypts for a very long time. People have shown that they can stay in different regions of the mouth. They just don't disappear. They can stay in tonsillar areas and other crypts and actually come back even after you place the implant. So you need to be a bit extra careful when you have had severe periodontal disease and generalized aggressive periodontitis situations are there. So I would prefer that we get rid of, if the patient can wait, certainly do a total extraction, give them removable processes, wait for the soft tissue to settle down and then go for a fixed option. If they do not want, they want to go ahead, then obviously caution them enough. And then I would still go for a zygoma implant option. We have done quite a few cases of similar situations where we have done total extraction. Be very careful with curating out all the tissue. That's very important that you really curate out very well and do some form of an osteoplasty and then do the implants. And we have had good results with it. But certainly, if I can have the option of doing it in 2 stages, I would prefer that.
Sankalp, what would be your treatment for this patient?
Of course, sir, on the upper arch, it will be 2 to 4 axial implant and 2 zygoma and 2 pterygoids. But before that, whatever experience I have, sometimes because of periodontitis, I have found that the maxilla is also involved, or maxillary sinusitis is also there, especially like the teeth, the molar which we are having on the left side. So because sometimes they are communicated with the sinus, then it is sometimes difficult to do a place a zygomatic implant, because as yesterday sir has also told, that I also follow the extended sinus lift technique, which is showed by Chow. So we enter into the sinus and then we lift it, the membrane, and then place the implant. So if you want to lift the membrane, the sinus should be clear. So then I would like to see that. And another problem is sometimes when we go for immediate extraction and implant placement in periodontitis cases, then sometimes because of the extensive inflammation, there is too much of bleeding is there. So if the gingival health is too bad, then I would like to first do extraction, wait for a couple of weeks, and then I would like to go ahead with the implant placement. But the planning will be same: 2 to 4 axial implant, 2 zygoma and 2 pterygoid. And mandible, of course, all on 4 or all on 6.
And Prasanth?
Yeah, now, Anjan, you have to permit me to share a slide, please, because I have a very similar case.
So, yeah,
I have a very similar case to show.
Switch between.
Okay, okay. See, we do such cases regularly under immediate loading protocols with basal implants. I just wanted to show you a case which is 9 years old from my files, something very similar, which we keep monitoring very regularly. There's absolutely no problem. It takes up very well under immediate loading protocols.
Okay, so the long-term, success rates are, what's the longest follow-up you have with patients like this?
Me personally, I've been using the system for 11 years. So full mouths I've done about 9 to 10 years ago. My first full mouths have come in about 10 years ago. And this particular case, which I wanted to show you, is about 9 years old. And I keep monitoring this patient very frequently. She's from Kochi, so she keeps reporting to my practice every 3 months for a review and checkup. And we make x-rays, everything is available. And everything is very clear. It's not just one case, we have multiple cases like this. We regularly manage such cases under immediate loading protocols.
Anjan,
okay.
Even you know, I try always to convert the cases for the immediate loading protocol. So what I will be doing, I'll be doing many sittings of scaling for this patient. Even if the teeth are grade 3 mobile, we will be splinting with some composite and all that, and we will be keep doing the scaling. And if a sinus issue is there, we can extract the posterior teeth. The day the gingiva has become completely nice, 1 week to 2 weeks of antibiotics and the complete, regimen, then we can convert this into the immediate extraction implant and immediate loading, the 2 zygoma and 2 anterior implants.
Yeah.
So
I
you are
think that's a
saying
good
that
point.
you will do the implant soon after after a period of 2 weeks. Is that what you're saying?
No.
When will you place the implants?
I said we will we will work on the gingival health. Even all the grade 3 mobile teeth, we do scaling for all our cases. And then once the gingiva is good, there is no bleeding, then we proceed for the extraction, immediate implant, and within 2 days, immediate loading. Temporary immediate loading.
To reduce your bacterial load. Yeah, that's a fair point.
Won't it suffice if you put the patient on antibiotics under oral antibiotic cover and do the extraction and immediate implant? I don't think you have to really wait for so long.
Just do the cleaning. You won't see any bleeding while implant procedure.
Prasanth doesn't raise the flap. No, the basic difference is we raise the flap and Prasanth do flapless. So probably because of that, he is not facing that problem.
And sometimes for the curettage, I am using a titanium brush. So the titanium brush, assures the curating of the sockets very nicely.
Okay.
Yeah, as Sankalp said, we don't raise a flap.
Move on.
That is a difference.
Yeah. So this is, I think, one probably for Girish to start with.
Anjan, there is one question from the other group. The question is,
okay,
specific implant type for irradiated bone and for cradle fibula. Any special consideration for them?
I think the problem thing is, I think that was discussed in the last webinar series when we talked about fibula rehab. It's quite a long answer for that. So I think maybe that's going to be difficult to take up over here. Irradiated bone, yes, I think we can ask everyone their opinion about irradiated bone. But I think as far as the fibula is concerned, I think we had a long discussion in the last webinar series, and that's available on YouTube, the one which Dr. Subramania Iyer was involved in. I think you would go back to that and, see, what the options are. So anyone want to take that about irradiated bone? Any of you have experience with, placing implants in irradiated patients?
Yeah, Anjan, the protocol, what we follow is basically either you do your implants before radiation, if at all you're doing. If you're doing a fibula or something like that, put it in and then allow it to get integrated and then do it. But if it is a radiation case which comes to you later on, I always believe in the fact that we have to wait for at least a year. Allow the radiation effect to completely settle down and then consider thinking about implants, but definitely tell the patients that there is a very high risk for osteoradionecrosis, for rejection, and the complications associated with that. We have tried in the past hyperbaric oxygen therapy also, but in some it has worked, in some it hasn't worked. There was a phase when I used to do a lot of hyperbaric oxygen therapy because we had a center in Bangalore, but now it's only for, nasty osteoradionecrosis cases we are sending them to. But definitely I would wait for a year and then think about implants.
Anyone else?
We did a case immediately while we were putting the fibula. So we placed the implant and all these things. But later on, he had some soft tissue exposure also. And because of radiation and this soft tissue problem, he developed trismus. So everything went fine, but then because of the trismus, we couldn't rehabilitate it. So there was no point in that case, the implant could not be utilized. So
that is another thing which we have to definitely take into consideration. because not only a lot of these patients have submucous fibrosis, but the radiation fibrosis which you get post-op is also a big concern. So you might have actually placed an implant, but you may not be able to rehabilitate them. So that's a very good point, Sankalp, which you have brought out. Absolutely correct.
Okay. So I think if we can go on. So Girish, while you're there, I think
yeah,
I'd like to ask you, this lady, I've got her CBCT as well, so we've got some measurements there. Very
What's
thin
the height?
mandible.
I can't make out the height. Let me get my glasses.
Okay. So it's about 7 to 9 millimeters. So in the mental region, it's about 7 millimeters and it's about 9 millimeters. It's such a wide, short mandible. And her concern is she can't wear a lower denture.
Yeah. I mean, this is a
not
very,
able to
very
retain a
atrophic
lower denture.
mandible.
So
I
what
mean, the height
options?
is very, very minimal. We're talking of about 8 millimeters is what we have there. I think if there are probably two options I would like to consider here. One is maybe just, I mean, trefoil is out of question because the bone is not there at all. I mean, the trefoil, you need basically a minimum. The height of the implant itself is either 11.5 or 13 millimeters. So we cannot basically go in and place a trefoil because the height of the bone is less here. The next option would be whether we can think in terms of grafting this area. That's one option which you can think about. Graft it, increase the height, or you could actually do a distraction and increase the height. That's another way in which you can actually increase the height in the symphysis area. But otherwise, you can also consider putting short implants and overdentures. Maybe 3 short implants and overdentures is what I would probably think about in this kind of scenario.
Okay. And would you be concerned about fracturing the mandible? Would you place the implants through the lower border?
If the width is good,
through the lower border, would you avoid the lower border?
See, lower border is a good cortical bone. So I think as long as you can preserve it, it's pretty good. I mean, rather than making complete holes through and through. But if the width is good, then the buccal kind of shelf and the lingual kind of shelf which you have there is good enough. And then probably it will not fracture. But still, at the end of the day, this is a very, very atrophic mandible. This is a pencil thin mandible. And you must tell your patients there is a high risk for fracture. And it can happen not just during the implant therapy, maybe even later on, they can actually fracture because you've already weakened the jaw. So that is something which definitely I would like to inform my patient before and take consent that we may have to take other measures also to fix the fractured mandible.
Now, can I comment on this?
I'd like to, yeah, sure. Okay.
Yeah. See, we place, we have 2.7 diameter bicortical screws available. So we place about 6 implants in the interforaminal region. And we will, as Girish was mentioning, if you perforate the lower border, you're likely to fracture the mandible again. So therefore, you've got to be guarded. But since we have excellent cortical bone in the interforaminal region, especially in the symphysis area, we can always angulate the implants towards the symphysis region to engage excellent cortical bone and bend them. And then we can always go for an excellent overdenture on top. And the other aspect is there were about 1 or 2 cases where I did have a fracture of the mandible, but then we could salvage the case because we are splinting the prosthesis again. We are connecting the implants together, so the connection itself acts as a stabilization, a fixation there.
Yeah, I think that is something I wanted to ask Venkat. Venkat, if you're there. I mean, my practice, I mean, this patient, we placed 3 implants and we actually splinted them for an overdenture because my worry was without splinting,
it can actually fracture,
we may actually put too much of forces on the implants and the mandible. Is that a factor, or would you consider, ball attachments or locators for a case like this, Venkat?
Yeah, this case, I think we should think about overdentures or probably because you need a tissue also to be supported, especially when you're thinking about it. Tissue supported as well as implant ball dentures or bar dentures is a good solution.
Yeah, but ball dentures, my concern is if you're individually loading these implants, are you actually putting stresses in the mandible?
Yes. The bar is always a splinted process, always a better solution. Always splinted is cross-arch stabilization in these kind of cases is always better.
Which is why I said if you opt for thinner implants, 2.7 millimeter diameter, you can place more number of implants, thereby increasing the BIC, and that gives you an excellent solution.
Guna sir, will you consider any nerve lateralization or anything in this?
If a patient prefers a fixed option, for me, the minimum criteria is 6 millimeter height in the anterior region, because if you have 6 millimeter height, then I can tilt and get a 9 millimeter implant in the anterior region. So because you get almost 50% more length possible by tilting it 45 degrees. So even if I have a 6, that's my absolute limit. If it's less than 6, I will graft. If it's 6, I can tilt the 2 anterior implants. The posterior implants, I will do a mental nerve repositioning and then tilt those 2 implants also. Because once you tilt the implants, the load, the stresses on the mandible are much lesser. And then you can use 3.3 millimeter implants up to 3 in the mandible, not maxilla. In the mandible, you can use 3.3, 4 implants all on 4. And Marlowe's got a long-term publication on that, more than 5-year results. So 3.3 into 4 implants, tilted, all the 4 tilted. And then you can do a mental nerve repositioning. And then you can do either a fixed or a bar and an overdenture on those 4 implants. That's an option.
Will you wait for immediate load?
If I get stability, I would load immediate. We have had also 2 patients with fractures, but that was earlier days when I did not tilt the posterior implant, when I went for a straight implant after nerve lateralization. With the tilting, I've not had any problem. But when I've had a fracture, somebody did mention that, when because you've got a framework that is cross-arch stabilizing the implants, it's very straightforward to open up and put a long titanium plate and fix that fracture segment.
And
you need to warn them about these 2 things. 1,
yes,
the fracture, and 2, paresthesia. Paresthesia is going to be there for 85 to 90% of patients. But only long-term paresthesia remains only for about 5% of the patients. And certainly even much less once you use piezo for nerve lateralization.
And if it is a choice of block graft, from where you will harvest, because it's difficult to harvest from the mandible. So
yeah, block graft, if you don't, I prefer allografts. Cadaver bone has worked very well for me for allografts.
Even for the patient above 60 in like this situation?
Yeah. If you have less than this, say 5 millimeter bone, I do block grafts with the blocks allograft. Rocky Mountain is a good choice.
Thank you, sir.
Now I have to mention something. Any other questions? Anjan, I have something to mention. See, coming to nerve lateralization, we don't do nerve lateralization, we do nerve bypass. So in a situation, if we have to give a fixed solution here, we can always go posteriorly and then bypass the nerve buccally and give a fixed option. That option is always there. And again, that will be a keyhole procedure. There's no open surgery.
Prasanth, is that freehand or guided?
It will be freehand.
I will be very, very wary of that freehand.
No, freehand. The reason is we routinely do this. The reason is what happens when we always in the posterior mandible, the nerve will be more towards the lingual aspect. So you can confidently do a bypass without any difficulty. It's the most important thing which I do in my practice. I always make a stereolithographic model, and I also examine the CBCT thoroughly. I don't allow my technician to draw the nerve for me because she might commit a mistake. So I'll prefer to see that myself to assess the position of the nerve. And then I also have a stereolithographic model with me so that I'm able to get a feel of the mandible. And then I can always do a buccal bypass without any difficulty, freehand.
Okay, Avi, any other questions from the audience? Any questions that you or any of the Nitin, anyone had, which have not been covered till now? Because
it's covered, sir. It's covered.
To the last part, the complications. So we'll proceed then to, I'm going to skip this one and then, so no questions. And so we'll come to complications. And what I want to do is show a few complications and see, how all of you experienced surgeons and practitioners would manage these. And hopefully, some of younger colleagues who might be viewing, hopefully will get some insights onto how to manage these patients. So this is the first patient. This is a 40-year-old software engineer who basically had, multiple bridges which were failing. They were removed. Implants were placed with simultaneous sinus lifting. And because grafting had been done and the patient wasn't prepared to wear a denture or couldn't wear a denture, some temporary implants were placed. And the patient came back 8 months later. This patient was a smoker, 10 a day. And when he came back, the implants were exposed. We put healing abutments. The implants looked stable. And a prosthesis was given, and within a month, of those implants came loose. So basically, the patient couldn't wear the prosthesis anymore, and this is the situation he ended up in. And even on the CBCT, it looked like we had actually formed some good bone, but the implants hadn't integrated. So I'd like to ask Samir first. Have you encountered any sort of issues like this where you've got adequate height of bone, you've got adequate graft material, but the implants don't seem to have integrated? Samir? Samir?
Hello?
Yeah, okay, we can hear you.
Hello?
Yeah.
Yeah. Yes, I have is like that. Did for 4 months, came back, we started. Hello? Am I
Sorry,
audible?
your network, I think it's, yeah, now you're audible. Yes, you were breaking a little bit. Yeah, fine, carry on.
Yeah, so we had similar situations. So I had to remove the implants. I had to wait for 2 more months and then come back and do the whole procedure once more. Yes, we faced like similar situations twice or thrice so far.
So do you think it's the fact that, you've just got calcified graft material there and not bone, or was it the problem of the implant?
I think
radiographically
everything seemed to be okay. Even in, with CBCT, we could make out there's a good osseointegration, but with CBCT. But I think there was no complete osseointegration in that case. It was just the bone dust which was there. We had like 6 or 7 millimeters of bone there. Patient was smoker. We have high rate of graft rejection. Also, we know the literature says that you have more amount of failures when a patient is a smoker and you do grafting. Sometimes they don't follow your instructions, not sometimes, most of the time. So only option left was for me, I don't do pterygoids as a routine. So I just wait for a couple of months after removal and do the whole thing again.
And the second time around, everything was okay?
Second time it was okay. And that time the patient was also more careful. He did follow our instructions, and surprisingly, one of our patients quit smoking just because he had to spend a little more next time.
Okay.
Yeah.
Sankalp, what would be your take? How would you manage this?
Sir, now once these implants are failed, am I audible, sir?
Yeah, you're audible, yes.
So now once these anterior implants are failed, I think the safest approach will be to have zygoma and if possible pterygoids. But again, the problem with zygoma also is that the one implant was in sinus and sinus lift was done and it was failed. So again, I would like to evaluate the health of the sinus before putting the zygoma. So if it will be in the 1 stage or 2 stage, that we have to decide depending on the health of the zygoma. But of course, I would prefer a zygoma. But these complications only force us to do zygoma, sir. Apart from those cases in which we don't have bone. Otherwise, this is not a uncommon complication. So with sinus lift, we very often we realize that we feel that our implant is in the a good amount of bone, but what exactly inside is we cannot make out. So sometimes during loading it fails. So
yeah, Guna, can I ask you? I mean, patients like this with failed sinuses, it seems sometimes very attractive to do zygomas, but the problem of having oroantral fistulas, because the buccal wall where they previously had a buccal window, sometimes ends up causing an oroantral fistula. I don't know whether you have a solution to that or whether you've had that.
Yeah, I've had a few oroantral fistulae, and for the same reason, I would be very careful about doing this patient with the immediate placement. Especially if he's a smoker, and the loads can be really excessive because opposing us, it's natural teeth. This will be a nightmare case if you're not careful. He's got opposing arch, natural teeth. He's a smoker. So first will be to convince him, to go for a smoking cessation protocol, the classic Bain protocol, 1 week before, 8 weeks after, or preferably continuously after give up smoking. Remove these implants, because I've had these issues in the sinus. What looks on the radiograph and scan as a calcified material may not be, a really good quality bone. So we have had issues when you think you've got good stability, and stage 2 you get ISQ values are dropping and it's a failing implant. In this situation, I would prefer to remove these implants, let everything heal, and let them go with the denture, and then come back and do a zygoma implants.
Okay. Prasanth, what would be your treatment option for a patient like this if they came to you?
Obviously, this is a case of peri-implantitis as a result of smoking. Again, because of the gingival recession which has occurred, the rough surfaces got exposed. So obviously that is the reason, and there is definitely a lot of loss of bone. So to make it really safe, I will not intervene immediately after removal of the implants, because again you run a risk. So I might consider waiting for 6 months and then go in for placement of the implants and immediate load protocol. Now all this decision will be on the table. If I'm able to get excellent anchorage while I'm placing the implant, then there is absolutely no issue. We can do an immediate load protocol immediately after removal of the implants. So it all depends on, we have to take a decision on the table.
And you would do this Flapless, and you would be worried about oroantral fistulae while doing your zygomatic implants.
In the case of zygoma, like we try to avoid an open procedure altogether. We try to go for a keyhole placement. Now, as Guna was mentioning, in the case of a zygoma, sometimes we may have to use a stent. Just for the zygoma alone, we may have to use a stent to reach out to the right portion of the zygoma. Now, even in such a situation, the risk of an oroantral fistula is minimal, because it is just a keyhole approach which we are doing, and we may have to put just a slot to bring the abutment into the right position while bending. We may have to. That's all. And once you're able to suture the mucosa above that cleanly, it shouldn't really create a problem for us in any way.
Okay. Anyone else would have any different way of managing this patient? Okay, we'll move on to the next one then. So this is a patient who came with pain in the 3-6 area, and you can see here this patient has had an implant placed. It's an implant fused to the adjacent natural tooth, and when we took the crown off, the implant was mobile and had to be removed. So Prasanth, I want to ask you, do you think this is placed correctly, and the fact of joining the tooth to the implant, would that have been the cause?
No, I don't agree with the plan of splinting. I don't agree with the plan of splinting the tooth to the implant in the first place. And secondly, the crown is a tulip crown, as you can see. You need to have 2 implants there to give a broad base so that you're able to avoid food impaction and a few other issues. So I'll any day prefer to place 2 implants there, and I don't like splinting it to the natural tooth.
Okay. what would be your treatment for this now? After removing, would you place an implant immediately?
Yes, we can definitely place an implant, not just an implant. We'll have to place 2 implants. We'll have to go down into the cortical bone, or the lingual cortical bone, engage the lingual cortex, and place another one posteriorly, so that you're able to replace the, it is the first molar. So you just get position, you position the implants exactly in the position of the roots of the molar, and that's it. We are able to immediately lower. This is what I'll do.
Avi, would you do anything differently, or would you do the same?
I was just typing the answer, so I just didn't see that.
Okay, so this patient, came to us with a, pain in the 3-6 region.
3-6 region.
So we took this crown off,
yeah.
And this implant was mobile, so we had to take it out. And my question was, one is, did this fail because the implant was not placed correctly? Is it because of the fact that the tooth was joined to the implant? And how would you rectify that?
This is the implant, very small implant, looking like a room.
Yeah, it's a cortical implant, supposedly.
I don't think it is a cortical. I don't see any cortical flutes there.
It's look like a temporary implant.
It looks like a temporary implant. Yes, looks like an orthodontic implant. I don't think it is a cortical implant, because a cortical, you'll have flutes there very clearly.
Yeah, so this is joined with the adjacent teeth. Yeah, so if you remove this implant, immediately you can place implant. If it is if there is a 2-wall defect also, we can do the immediate implant and grafting, or otherwise we can wait and do the delay implant.
Yeah. But what is your take about, joining implants with teeth? Is that something, would you do that? Would you try to keep them independent?
No, we don't do like this, and that is not advisable. But in a very rare situation, I rarely do this. When a patient is an old patient, there is a economic constraint. There is a 1/8, which is very good, like upper 8, and that is very good. And you have a few missing teeth in between, and you have a bone only in second premolar region or first premolar region. Then we put an implant anteriorly, do not do sinus lift, and joint it to explain to the patient. Then it will work for a few years, or it may work forever as well. And then only we do that. Otherwise, we don't do it.
Okay.
I think, Anjan, I don't know. I mean, a lot of these kind of things we come across these days more and more. Unfortunately, whether it is a transitional implant or whatever, whether it's an implant or a pin, I don't know. But definitely, I don't think we should ever be joining an implant crown to a natural crown. That is probably the message which we have to very, very strongly give, unless it's absolutely necessary. I mean, unless you put a stress breaker in or anything like that, I think it goes against every principle. So you have a rigid kind of principle on one side, and then you have the periodontium, which is actually giving that kind of movement. So I think it's very, very important that this kind of quackery should never be encouraged on.
Yes, sir. Fully
agree.
Okay. Yeah. So this is an all-on-4 which we have done for one of ISU doctor's father, and unfortunately, during the healing phase, we lost one implant. So I mean, the patient had already, on our teeth for a while because we had taken our teeth, allowed things to heal. So we decided to go ahead and proceed and make a framework. What would be your option for further rehabilitation for this patient? If you ask Sankalp, would you go ahead? I mean, there looked like there's plenty of bone there. Would you place another implant? Would you place more than one implant? Would you place a pterygoid implant for safety? What would be your treatment plan in a situation like
Definitely, sir, one angled implant first. And then it seems that there is enough bone in the sinus region also. So we can go for 2 small straight implant also. Or if the width is not sufficient, then we can go for 2 pterygoids. Means 3 implants I would like to place more, whatever it is. 1 distal tilted implant and 2 either straight or 2 pterygoids. And then change the prosthesis.
See, in all these cases, the nasal floor is not anchored. So we should anchor the nasal floor with this implants as well, using 18mm or 16mm implants, whatever is required.
Yes, yeah. these implants are too short. Yeah, that's probably
very
one of
evidently the basal cortical, yes, the nasal floor is not engaged. That is the reason, and the cantilever has also played its role. Definitely.
I have a different philosophy on this, Anjan, if I may interfere.
Yeah.
A lot of times we get bogged down to certain concepts and we think, oh, we should only do 4 implants, even though they're tilted. I think that philosophy many a times is wrong. Yes. I think when you have a scenario like this, when we have significant amount of bone, I would actually to think in terms of long-term probably put 6 implants over there in the initial phase itself. So I think even if you lose one, I think you still can basically restore the whole thing and still maintain the bridges, something which I believe in.
Absolutely.
So that's where I think more number of implants is probably the key, especially when you have good amount of bone. The initial planning itself, I would rather put, 6 implants and then go in for conventional, or even the distal ones can be slightly tilted and you can still have 4 in the front. So I believe that is probably the way in which we should do it. Sometimes you say all on 4 or none on 3. So that is something which we have to really, really be cautious about.
Absolutely. There's a saying, if you go on a long journey with 4 tires in your car without a stepney, then you're in trouble.
So Guna, what's your philosophy with this? Do you think more than 4 or 4 is enough?
I would go with Girish. If you have enough bone, around 4 is only the second option. If you have enough bone, you should go for the classical minimum 6 axial implants. Yeah. Even if it has an indirect sinus lift for the most posterior implants, definitely try to engage the cortex of the sinus flow. Go for 6 axial implants. And during this interim phase, I would also, one more thing I may do is probably even, I won't leave the cantilever that long because you still have the loads exceeding, on your upper bridge. I would section that framework just distal to that and not leave it, because once you have that cantilever, they're still going to use it. So I would be very concerned about that even during the interim phase.
The 6 implants, as Dr. Girish Rao was speaking about, would you place it in the region of first molar or in the second molar? The distal implant.
The distal, I would go all the way up to the first molar. I think probably 1 over here, 1 here, and then 1 over here. So it should be, the longer the span, the better it is.
That's till the second molar.
Yeah.
Okay.
My preference would be to take the pterygoids always, to avoid distal cantilevers. Always.
Yeah, distal cantilevers, even if they're placing in the 7, there's no cantilever, right? You're placing in the second molar.
Yes, 7, there is no cantilever. Yeah, in this case, in the case of 7, there'll be no cantilever. But still, you'll get much more stable support if you're able to place the pterygoids. That's always better, because the 7 area, you have the sinus there, which is most likely to pneumatize, and you will never get good bone there. Whereas the pterygoids, you get excellent bone. So any day, pterygoids will be a safe bet there.
Yeah, it's okay, but they're doing delayed loading, and you'll always have a remodeled bone formed, and there's no cantilever. But in your case, but what you're saying is you place double pterygoids also. Still, you are placing just 6 teeth till the first molars. There's no point having chewing surfaces till 7, because only the pterygoids are taken as support. After placing 10 to 12 implants in the maxilla, the number of chewing surfaces are very less.
Yeah.
So instead of that,
no, that is sufficient. You don't need more of chewing surface. You just need for proper chewing, you just need 6 to 6. That is more than sufficient. We are taking anchorage from the pterygoid only to ensure that you avoid cantilevers, and you're depending on the excellent cortical bone which is available in the pterygoid. That's all. It's as simple as that.
No, 6.
But I think, Dr. Prasanth, there's enough bone here to place 6 to 8 implants, and that's the first.
Definitely, that is another option. I agree with you. I agree with you. Yes. Yeah. In this case, pterygoid is not mandatory. It is not essential. You can always go with 6 to 8 implants between the sinuses. Absolutely fine. No problem. I agree.
Okay. Anyway, so maybe I'll just complete the story with this chap. But we went back and placed that implant again, delayed loaded, when he finally attached it to his prosthesis, and we told him we're putting implants. And he passed away about 3 months later after the final processes of this was attached. So we never got an opportunity to put in 2 more implants for him. So this is the next patient, and this patient, again, we did an immediate load. He had a bone premolar to premolar, and it looked like an ideal case for an all-on 4, which is what we did. And this is a chap who used to live in the US, and he would travel back for work, and he called back a month after having the prosthesis, saying some of my front teeth chipped off, and got to go back to local dentist in the US and get these repaired. And he came back 4 months later, and this is what you saw on the X-ray, that it actually loosened one of the implants, and one more implant had undergone fibrous integration, and he only had the 2 anterior implants integrated in the maxilla. So how would you do this differently? I mean, we discovered that this probably patient was a bruxer, which we only identified after this failure occurred. But is there any way of identifying bruxers so that we can over-engineer? And would you over-engineer? Maybe you can ask Venkat this. How would you manage a patient? Is there a good way of identifying bruxers, first of all? And how do you over-engineer? How do you plan them for treatment?
This case probably because the distal implants, I think these are noble implants. Is it noble?
Yeah, they are the noble actives. Yeah.
Yeah. So the main problem with noble implants is when you're putting your distal implants in the posterior, it should not be beyond 30 to 40 degrees, because your multi-units maximum, which you can restore it, you cannot make it parallel. So that's one problem, especially the multi-units maximum is 30 degrees. You probably require a 50 or 60 degrees in this kind of to correct the angle of those implants. So one of the major reason could be a screw loosening, because any case starts with the prosthetic failure. And any kind of screw loosening, and then later leads to screw breakages, and then leads to surgical failure. So surgical failure, I think this surgically it should not be a problem, but the problem is the screw, the restoration, prosthetic rehabilitation cases. Coming to the bruxer, it's really difficult unless until you see a masseter, heavy masseter there, having a patient having very strong muscle. So especially when your patients are coming from abroad and traveling more, I prefer always a splint to avoid it, be more cautious. It's better to give a splint before going with the final restorations.
I see bits of surgical failure here. That one is the nasal floor is not anchored. Second, the angulation is like that. So this is also a small surgical failure, and that has led to the further problem to the prosthodontist.
Probably
this patient, sorry, yeah,
the angle probably is too much, and
yes.
It's really difficult to check in the OPG whether it's having a nasal engagement. Probably you may have gone more down the nasal floor, more palatally. You may get the nasal floor anchorage, but it will not be shown in the OPG. But main problem is the prosthetic failure, which I'm looking at, and the cantilevers. When probably you may have gone for a cantilever in the upper in this particular case.
I really feel
in terms of rehabilitating this now, so basically both the distal implants were gone, and there was very little bone over there. So what would be your treatment options for this patient for the rehabilitating the maxilla?
Still we have a bone here in different dimension. We have a nasal floor, which is approximately 3 to 4 millimeter here, as well as the direction is also, if corrected, then we have enough bone here. It can be placed in the same.
There was no crestal bone available in the canine premolar region.
Then to load immediately, zygomatic is a good option, 2 zygomatic.
Yeah, I mean, I'll tell you, yes, we did 2 zygomas, but yeah. Would that be sufficient? Because we put in 2 zygomas, but for a bruxer, again, I suppose the more of these cases you do, the more religious you become. You pray that these don't break and they don't break something else. But we put in 2 zygomas and we gave him a prosthesis on 4 integrated implants eventually. But is that sufficient, or for a bruxer, would you look at more number of implants?
I personally, I would prefer to place the pterygoids, more number of implants, and then also give Botox injections to ensure that the muscle activity is reduced. So that helps in controlling the bite pressure in a bruxer.
Pterygoids, I think it should
Guna,
be there.
can I ask you, what would you do with a patient like this? Pterygoids, yeah.
I would do exactly what you did. I would remove the posterior implants and go for zygomas. And then once you restore them, splint them and restore them, I would also look at soft splint, night guard to be worn regularly, and proactively also do Botox injection on the masseter.
Botox,
that really
yes.
helps.
Yeah. In fact, he comes back every 6 months, and we put in a little bit more Botox as well for him.
Yeah, I think that's a good idea. At least once in 6 months, once a year.
He hasn't broken anything.
Yeah, and nice sprint. My only why wasn't this these implants splinted?
He had a temporary prosthesis actually. These are temporary cylinders.
Even in the temporary prosthesis, we need to splint. That is very important, as Dr. Guna sir was speaking about.
Yeah. So the temporization as well. I mean, I've gone away from these, and I've usually tried to get some sort of a metal substructure made by the lab. Is that important, or is all acrylic okay for the temporary, Venkat?
I think we need to
Very important to splint it.
It's better to always.
How do you splint temporaries? So how do you get a metal framework done even for the temporary, or?
Yeah, we can have a metal framework, or I do extraoral welding, and I do it. See, basically here you have to dissipate the forces from one implant to the other, and acrylic is a force dissipator and doesn't transfer the loads. So it's always better to splint the implants, even if it is a temporary denture what you are giving.
Okay. Pardon me, but do you think in this case, even if we would have splinted it with the metal acrylic prosthesis or something like this, in the long term it would have lasted? I think it is a clear-cut case of a deficient bone in which we have placed tilted implant. In the first go only, we would have opted for zygoma implants, so we could have avoided this case, this complication.
Yeah.
The implant size.
I agree. I mean, in hindsight, probably a zygoma would have been. These are 15 mm implants. The posteriors are 15s.
Okay. Can I just say another thing? Anjan?
Yeah. Samir, yeah.
If you see your temporary prosthesis which you have given a good occlusion in the posteriors as well. Paulo Molo doesn't say to have a good occlusion in the posterior region. He says just have a touch occlusion in the canine region, nothing beyond canines. So that could also add up with the bruxism, that you have the failure of your distal implants.
Yeah, I mean, we had given a clearance. There was a millimeter clearance in the posteriors.
Okay. Yeah.
And in fact, that's probably why he broke the anteriors, and that's why it looks like that the white has collapsed.
Okay.
Okay, so that was the last case.
Bite also, especially when you're thinking about giving this, the bite, I think it should be as shallow as possible when you're planning to go for acrylic bridges. So the amount, it should be as shallow as possible, incisal guidance.
So an edge to edge,
this looks more than 2 mm.
Incisor contact.
Yeah.
No, this was, I mean, that again, I think was a mistake that, he actually originally had a D bite in his original occlusion. And I think we, copy that into the, temporary. And I think that was like a mistake probably. So we'll give an edge to edge on your anteriors for most of your patients, or what would you?
Yeah, always, if it is class 2, not required because you have enough horizontal overlap. So you can give a deep bite kind of thing if you have a kind of class 2 situation. But if it is a class 1 situation or class 3, pseudo class 3, and you're trying to give class 1, you need to be more careful about going for shallow incisal guidance. And especially the posteriors, the cuspal angles, as you are using monoplane kind of occlusion, 20-degree cusp is as good. No problem.
So that was the last case for discussion. Any comments from anyone about the whole program? Maybe we can start with all the panelists and ask them their feedback about any last minute messages for the audience before we finish. Starting with Samir. A quick one sentence, anything.
First of all, let me just thank. One sentence, I would just sum up. There are different ways to treat one single case. It's not that every technique would work in my hand. So we need to master one technique and then go on to another. And that's it. So just find what works in your hand and then keep doing that time and again for all the youngsters. Thank you. And thank you, everybody. Thank you, AOMSI, for for making me part of this wonderful discussion. Thank you.
Okay. Sankalp, any message for the audience? Any last minute take home message?
Sir, my message would always be that it is not the implant which fails, it is the dentist or the surgeon who fails. So never blame implant or never blame any lab or anything when you fail. Just to accept the failure and don't linger it on. Most of the time, I had done it. I know that this implant has failed. So then we will not tell the patient, we'll prescribe some gel or some medicine or something and we keep lingering it on. So it only adds up the complication. So as soon as you find that this implant has failed, you should accept it. You should tell the patient and you should go for rectification. This is all.
Prasanth, any last minute, just one sentence, anything quick, any last message?
First of all, I should congratulate you and the AOMSI team for having
only one sentence. Only one sentence.
Okay.
If that's your sentence,
the
then
one sentence is this: to all my friends, just go down to the fundamentals of your subject, learn the anatomy, learn the bone physiology, and the answer comes to you. That's it. That's it. And practice, learn from the right mentors, practice, and then that's it. You perfect your technique. That's it.
Any last messages for the audience?
Medical history, treatment planning is more important than all the other steps. Thank you.
Okay. And Venkat, from a prosthodontist perspective, anything that you want to add?
I think prosthetics are the main thing, because if you're going for zygoma or graft solutions or graftless solutions with pterygoids all on fours, final is if it has to fail, it will fail in the first year. The surgical failure will be in the first year. But the prosthetics, if anything, if the occlusion is not proper and you're not maintaining and maintenance is not good, it will definitely lead to a failure. Any kind of technique or anything.
Girish, any?
I think the more we start, the more we do, the more complications you will come across. And you need to be certainly prepared to basically handle these kind of complications. But I think an excellent clinician is one who can actually prevent any of these complications. So I think that is the kind of thing, planning, and think about the end in mind. So it's reverse engineering and implants, work as a team, and I'm sure you'll be successful.
Yeah. And I think that's probably, the message that, complications
Anjan,
will occur. And
Anjan, there is some questions from YouTube. Can it's posted in the WhatsApp? Can Avi take them to you? Avi?
Yeah, sure.
Yeah, if you can take those questions, please.
What is is there any role of clindamycin irrigation?
Anyone wants to take that from the panel?
I don't think so, sir. Any role of clindamycin irrigation. If you have not followed the aseptic protocol, that clindamycin also will not help. So, as we have already discussed, we have to follow the protocol. Then this clindamycin or betadine, it is not needed.
The question is to Dr. Prasanth. If mandible fractures and you got displaced, then would you go for a plating, intraoral or extraoral? After plating, would you proceed with basal implant procedures or quit?
See what happens if there is a fracture when you are restoring the prosthesis, cross arch fixation. When you're doing it, automatically you are able to restore the contour of the mandible easily. But then you need to have a plating at the base. Definitely, you need to have an additional plate to reinforce it, and the patient can continue to function without any problem. Certainly, yes. We may have to use a reconstruction plate also, rarely, if the mandible is really very thin. Hello?
Yeah. Rest are covered somewhere or other way. It's answered some or other time.
There was just one analogy which I wanted to use.
Should we conclude or?
Yeah, just one analogy which I wanted to use. I always say the prosthesis is the wife and the implant is the husband. And the two children are aesthetics and function. So there should be a perfect understanding between the implant and prosthesis. Otherwise, you're in trouble. That's. Thank you.
Pritam?
Yes, Anjan. If there's no more questions, you can proceed for the conclusion.
Okay, so
I think your co-host on YouTube
session.
also joined you here now.
Okay, that was a wonderful session. Thank all the panelists, all the co-hosts as well for helping in organizing this. And I think my message would be treatment options. The reason why I we titled it that way was to think of all the options. You have lots of tools. You have to weigh them in your mind and decide what works for you, and always weigh the pros and cons and think of the patient first. It's not about how expensive it is or how successful it would be in someone else's hands. It needs to work in your hands. That's my message. Thank you.
Thank you, sir.
Thank you. Thank you very much.
Thank you, Anjan.
Thank you.
Thank you, sir. Thank you.
Pramod?
Well
Pramod?
done. Very well.
Yeah, I'm here.
Yeah.
I'm here.
Yeah, go ahead.
Yeah, let them conclude. Let them conclude.
Yeah.
Then...
Yeah. Guna sir, please go ahead.
You're saying.
No, there was nothing. I just congratulated Anjan for his great show.
Thank you, sir.
Yeah, it was.
Superb show.
Okay, Pramod. Praveen, you're there? No, don't leave. Music. We'll end with the music. So
yes, sir.
You can see the Bahubali.
Hold on now.
Yeah. Praveen, hold on. Let Pramod conclude first.
Yeah, I just want to say special thanks to Anjan for coordinating this entire series. When I asked him, he took it up with great enthusiasm, and it's a lot of hard work. He coordinated between people and got a lot of people, not only from the specialty of maxillofacial surgeons, but he got people from other specialties as well, and then did a wonderful job getting Mentimeters, writing Mentimeter questions and coordinating, and special thanks to Anjan and special thanks to AOMSI side, and I'm glad that we could get some people out of their self-imposed exile / with this, and I hope you're a great motivation for us. So don't think otherwise. Your presence makes us do better and do more. So please don't go back into exile. That's a special request to Dr. Guna, who said that, and even Dr. Kishore said that during the last session, that and he was happy to be back among the AOMSI folk. So we are grateful that you're here, and thanks to the entire team as well. Anjan and Preetham and Kanan and Amit. We talk every day, plan for things, and so it's been great. And this is not the end. We are planning for the season 3. And of course, I special thanks for people who came on YouTube. It's very difficult job, and there are people who did on YouTube and Zoom, took a lot of time out, like Avi, Venkat, and Mukul, and a lot of people, and the people who came on Zoom. It was a great effort by everybody. So special thanks to all. And as I said, this is not the conclusion. We are coming up with something different, and hopefully we will come to you pretty soon with that.
And we'll meet all of you for the debriefing, all the panelists and the co-hosts.
Yes.
Okay.
And to all the listeners, if you're out there, please go to your Twitter, search for AOMSI, and the link has been shared in all the WhatsApp groups. Please go to your Twitter handle and then give feedback. We need it to improve on our current practices. So kindly, it will take just a second, go back and use the Twitter.
Requesting all participants, please mute your video and audio so that the clarity of the music will be clear. Please mute.
Yeah, go ahead, Praveen.
I think the wrong music played. He'll redo it. Sorry. The wrong music played. He'll redo it. Looks like Sam liked this one.
I couldn't understand the meaning, so
okay. Now we'll play the one which you'll understand.
Okay.
Thank you all.